سك الصوت اسمه العلوم.
وين ابوي؟ بابا ها صح؟
أدري هو مطلوب منهم، مطلوب يسجلون البيانات.
صامت حوالي
بابا لبس هذه كل يوم تحملها.
وشو؟ ايش
لا ركض. السلام عليكم.
Assalamu alaikum wa rahmatullah. Welcome everyone to our first day of our webinar, Diabetes Education and Management. First of all, diabetes is a group of metabolic diseases that are characterized by hyperglycemia that result from defect in insulin secretion, insulin action, or the both of them. So hyperglycemia of diabetes is usually associated with long-term damage, dysfunction, and even failure in various organs, especially those in the eyes, kidney, nerves, heart, and the blood vessels. Diabetes is approximately affecting 24 million Americans and 54 million in the pre-diabetes stage, and over 200,000 individuals each year die from diabetes complications. So diabetes, as you already probably know, is divided into distinct types, type 1, 2, and gestational diabetes, with other types that are identified recently. So in type 2 diabetes, which comprise 90% of diabetes cases, it can affect both the genetic and environmental factors. So the types of diabetes affecting children and teens are listed following, and the adiposity that are associated with inflammation and insulin resistance are strongly implicated in the development of type 2 diabetes, as well as the occurrence of the metabolic syndrome. So the activation of the nuclear transcription factor of B has been linked with a variety of inflammatory diseases, including diabetes. In addition, antioxidant species, herbs, and omega-3 fatty acids can help to suppress the inflammatory pathways. And moreover, amino acids are also important in diabetes, as they support the cell signaling, the gene expression, and also the hormone synthesis. And while the physiological concentrations of amino acid and their metabolites, such as, for example, nitric oxide, the voluminase, the glutathione, and etc., are all required. And some elevation in their levels can produce ammonia or homocysteine or the asymmetric dimethylglycine, which all contribute to the oxidative stress and oxidative damage. So dietary supplementation with one or more or a mixture of the arginine, cysteine, glutamine, leucine, proline, and tryptophan, which are all essential amino acids, can be beneficial for ameliorating the health problems, including the fetal growth restriction and GDM, the neonatal morbidity and mortality, obesity, diabetes, and cardiovascular disease, with also the metabolic syndrome and infertility. Diabetes can be classified in numerous ways, but according to the etiological classification, it is divided as the following. The first type is type 1 diabetes, which results from an autoimmune beta cell destruction that usually lead to absolute insulin deficiency. While in the second class, which is type 2 diabetes, it results from a relative deficiency or insulin resistance. And the third type or class is the gestational diabetes mellitus, which is diabetes that is first diagnosed during pregnancy in an otherwise healthy female. There are also other specific types of diabetes that can occur due to other causes, such as genetic defect of the beta cell function, or what is referred to as the maturity onset diabetes of the youth. This is a type 1 diabetes, but type 2 diabetes, but results in children. It can also, there is a genetic defect in insulin action, such as in Libertines and the Robinson-Medellin syndrome, or the lipotrophic diabetes. Also, a third type is the diseases of the exocrine pancreas, such as pancreatitis, trauma or pancreatectomy, neoplasia or cystic fibrosis with hemochromatosis, and fibroculose pancreatopathy, all can lead to the development of diabetes. Another etiological classification for diabetes are endocrinopathies, such as acromegaly, or in the condition of Cushing syndrome, in glaucomas, or in hyperthyroidism, for example. There is also a drug or a chemical-induced diabetes, such as those due to nicotinic acid or the glucocorticoid or thyroid hormone issues, and also the thiazide medication and the alpha-interferon. Also, diabetes in some cases can result as a result of infections, such as the congenital rubella or the cytomegalovirus. And there are other genetic syndromes that are sometimes associated with diabetes, such as Down syndrome, the Klinefelter syndrome, the Turner syndrome, or even the Huntington chorea or the myotonic dystrophies. So that was the etiological classification for diabetes, and there is a general classification also of diabetes. So in general, the classifications are type 1, the immune-mediated, type 2, the insulin resistance, and type 3, the maturity onset diabetes of the youth. So in the first type 1 diabetes, which is also referred to as the immune-mediated diabetes. Usually, the persons who are affected are often not obese and have a recent weight loss. In addition, it is occurring in a short duration of symptoms such as thirst and frequent urination, and it has the presence of ketones at the diagnostic stage, with about 35% of the people who are affected presenting with ketoacidosis. It often has a honeymoon period after the blood sugar are in control, during which the need for insulin diminishes for a while, and a low dose of a long-acting insulin such as Glargine or the Lantus can prolong this honeymoon period or phase. So ultimate complete destruction of the insulin producing cells needing exogenous insulin for survival is mandatory, and ongoing risk of ketoacidosis is also possible for people with type 1 diabetes, and only about 5% who has family history in the first or in the second degree relative of diabetes will develop diabetes or have 5% risk of developing diabetes. In the second type, the type 2 diabetes, the insulin resistance, usually individuals with type 2 are usually overweight at the diagnosis and has little or even no weight loss. Also, they usually have sugar in the urine, but no ketones are present. And as many as 30% of individuals will have some ketones in the urine at the diagnosis time. And about 5% of those with type 2 diabetes will have ketoacidosis during diagnosis, and often little or even no thirst and minimal increase in urination are present. Also, people who are affected with type 2 diabetes have a strong family history of diabetes. and about 45 to even 80% have at least one parent with diabetes. Also, the diabetes may span many generations of the family members, and about 75 to even 100% have a first or a second degree relative who has diabetes. Typically, there are certain ethnic groups who have a higher risk of type 2 diabetes, including African, Hispanic, Asian, or Americans who have Indian origin. So disorders are likely to cause insulin resistance are common, and about 90% of children who have type 2 diabetes have also a dark shiny patches on the skins, which is known as acanthosis nigricans, which are most often found between the fingers and also between the toes. In addition to on the back of the neck, which is often known as the dirty neck, and in the axillary creases. The third type, which is the maturity onset of diabetes of the young. This is a rare form of diabetes, and several varieties exist in people who have this type of diabetes. It has usually early age of onset between 9 to 25 years of age with an autosomal dominant inheritability. So this type results from defect to insulin-producing cells that is caused by a genetic defect in the pancreatic beta cell function. And the symptoms that run the gamut from mild elevation in the blood sugars to severe disturbance. So MODY can occur in all ethnic groups. There is no specific preference, and the gene abnormalities are rare and can only be identified through testing that is currently available only in research laboratories. And individuals who have this type are usually not obese. It is believed to develop due to environmental stressors such as illnesses or puberty, and this can unmask the genetically limited insulin secretory reserves of the patient with an undiagnosed MODY. And unlike type 1, it doesn't cause any polyuria, thirst, or extreme hunger, and the primary goal for the treatment is to have euglycemia. Also, fasting on insulin and the C-peptide levels are usually normal or even slightly elevated. We will be taking a break now for a last prayer, and then we will continue with assessment in diabetes. Assalamu alaikum wa rahmatullah. So now we will continue with discussing the assessment in diabetes. First, we should assess the patient's physical or mental status as the mood disorders. Also, we should assess if the patient was using contraceptions as reproductive and their sexual history with their current treatment and medication, in addition to meal planning, results of glucose monitoring, the patient's use of their data, including their recorded blood glucose level, their if they are following their treatment in precise, and their dietary guidelines. Also, we should assess their eating patterns, nutritional status, and weight history, in addition to growth and development in children and adolescents. We should also assess their exercise history, their family history of diabetes and other endocrine disease, and also their frequency, severity, and causes of their acute complications, such as ketoacidosis and hypoglycemia. Also, we should assess their history and treatment for other conditions, including if they had other endocrine disease or eating disorders. In addition, it is important to assess if they have any infections, such as in the skin, in the foot, dental, or any types of infection, even if they had previous infection or current infections. In addition to this, the laboratory tests with symptoms and special examination results that are related to the diagnosis of diabetes are important in the assessment stage, and also their lifestyle, their cultural and psychosocial with educational level, and the economic factors that can influence the management of diabetes. So it is important to have a full picture of their situation to understand what obstacles they might have in controlling or managing their diabetes. Also, we should assess if they are taking any other medication that can affect their blood glucose levels, and any previous treatment programs such as nutrition and diabetes self-management education, their attitude toward their treatment, and their health beliefs. And an important thing to always assess is their previous glycated hemoglobin records. We should, in addition, assess their risk factors for atherosclerosis, if they are smokers or if they have hypertension. Also, we should assess their obesity or if they have obesity, dyslipidemia, and their family history. In addition, their symptoms of celiac disease, especially in patients who have type 1 diabetes. We should also assess their symptoms and if they have any treatment for chronic eye, kidney, or nerve disease. We should also assess their bladder, their gastrointestinal function, their heart, and the peripheral vascular system, even with the foot and the cerebrovascular complications that are usually associated with diabetes. We should also assess if they are, as we said, smokers, having substance abuse, or any controlled or uncontrolled use. For the evaluation of diabetes, we should screen all patients for prediabetes and their diabetes in those who are considered at high risk and asymptomatic or undiagnosed adults and children. This is usually conducted using an oral glucose tolerance test that may be considered in patients who have an impaired fasting glucose test result to better define the risk of their diabetes. Also, testing for diabetes should be considered in all individuals who are over 45 years of age, and in particular, those who have a BMI of 25 kg parameters, and those if they have normal results, then we should test or repeat the test at least at 3 years interval to assess if they had developed the risk or became at a risk of becoming pre-diabetic. So the classic symptoms of diabetes include polyuria, polydipsia, and unexplained weight loss plus one of the following. This is, of course, in type 1 diabetes. So the first one is symptoms of diabetes and a casual plasma glucose of 200 milligram per deciliter. So casual is defined as any time of the day without regard to the last time since they consumed their last meal. So a fasting plasma glucose tolerance test is also, or a 2 hours oral glucose tolerance test with 75 grams of glucose load, or both of them are appropriate. And if they had a fasting blood glucose value of 126, so the fasting is defined as a no caloric intake for at least 8 hours. If they had this, then they have classic signs of diabetes. Also, for the 2 hours plasma glucose test, 200 milligram result is considered high, and the test should be performed using a glucose load containing the equivalent of a 75 gram of anhydrous glucose that is dissolved in water. In terms of the medical nutrition therapy, we should first replace the term of diet therapy, as there is no single diabetic or ADA diet specified. So the recommended guidelines or diet is individualized nutrition prescription based on the assessment finding and the treatment. So we cannot have a one typical diet for diabetic patients and apply it to all of them. Their diet or dietary intervention should be specialized for each patient. So medical nutrition therapy should consider the patient's usual eating habits and other lifestyle factors. And a strategic patient counseling should identify the benefits of the plan, such as self-efficacy and obstacles, and also the lifestyle changes, challenges or changes in the patient that is willing to make. So this intervention will help to reach the desired outcome by controlling the blood glucose level. In addition, using an open-ended discussion and counseling encourages the client or the patient to assess and determine a realistic self-management plan depending on their situation. Also, medical nutrition therapy should be offered in phases according to the patient comprehension and readiness. So we shouldn't start by immediately replacing their usual diet, but we should take small steps to improve their diet in general over time. So the nutrition care process included assessment of the nutrition diagnosis, the intervention that is also followed by monitoring and evaluation. So we should monitor the blood glucose at all times, their medication, their physical activity, their educational level, and behavior modification, in addition to evaluating their cardiovascular and renal status, which are all considered important and relevant in diabetes. In addition, we should prevent any complication such as hypoglycemia or hyperglycemia as much as possible. Also, a diabetes educator is defined as a health professional who has mastered the core knowledge and skill, the communication, counseling, and education in terms of diabetes. So the credential of certificate of diabetes educator designated for professionals who have at least 1,000 hours of direct diabetes teaching, and also those who have successfully completed their examination. And an advanced credential has been developed for dietitians, nurses, and pharmacists who have an advanced degree and meet their experimental requirements, as this is known as BCADM. So when managing diabetes, there are key concepts that need to be followed. First of all, in terms of glucose control, an improved glycemic control benefits people who have either type 1 or type 2 diabetes in general, as each 1% reduction in the A1C blood test results, for example, from 8% to 7%, then the risk of developing microvascular diabetes complications such as eye, kidney, and nerve disease is reduced by 40%. So even a simple improvement or change can result in a significant or have an impact, a greater impact on health. And the more stringent glycemic goals, such as the usual A1C levels of 6%, can further reduce the complication at the cost of an increased risk of hypoglycemia. And the less intensive glycemic goals can indicate a patient who have severe or frequent hypoglycemic attack. In addition, the postprandial glucose may be targeted if A1C goals are not met despite reaching the preprandial glucose goal. And the goals, as we said, should be individualized, and the lower goals can be a reasonable choice based on the benefit and risk assessment, all depending on the patient's condition and their blood glucose levels. In addition, certain populations, such as children, pregnant women, and elderly, can require special consideration as the following guidelines. So the value by age or years for those in regard to the preprandial glucose, the bedtime glucose, and A1C. First of all, for toddlers and preschoolers aging between 0 to 6 years, their preprandial glucose level should be between 100 to 180, while their overnight can be a bit higher of about 110 to 200, and their A1C level shouldn't be less than 8.5, but should be more than 7.5, as they have a high risk and the vulnerability of hypoglycemia. For school-aged children between the ages of 7 to 12, their preprandial glucose can be somehow less, between 90 to 180, and their A1C level should be less than 8%. As they have risk for hypoglycemia also and a relatively low risk of complication before puberty, their blood glucose level should be somehow flexible. While for adolescents and young adults between 13 to 19, their preprandial glucose is somewhat limited to 90 to up to 130, while their bedtime or overnight level should be between 90 to 150. And their A1C levels should be less than 7%. So those individuals have risk for severe hypoglycemia, developmental and also psychological issues, and a lower goal of 7% is reasonable if it was achieved without any excessive occurrence of hypoglycemic attack. And for adults over the age of 20, then their preprandial glucose is between 90 to 130, and A1C should be less than 7%. Also, a peak postprandial of 180 for 1 or even 2 hours after beginning of a meal is considered normal for them. In terms of blood pressure control, the goal is to have the blood pressure on 130/80, and we should restrict their sodium intake to 2,400 milligram per day, and we should assist in the control of hypertension. So blood pressure control can reduce the cardiovascular disease of the heart diseases and stroke by approximately 33 to even 50%, which can also reduce the microvascular disease risk of eye, kidney, and nerve disease by approximately 33%. So in general, for every 10 mm reduction in the systolic blood pressure, so the risk of any complication related to diabetes is reduced by 12%. For the control of blood levels, we should have improved control of cholesterol or the blood levels, such as the high-density lipoprotein or LDL and triglyceride, which can reduce the cardiovascular complication by 20 to 50%. So the goals are to keep the total blood cholesterol level minus the HDL level, that should be 130 milligram per deciliter, while the LDL should be 100 milligrams and the triglyceride level should be 150 and HDL should be 40 in men while 50 in women. There are also some preventative care practices for the eyes and feet in specific for patients who have diabetes. So detecting and treating diabetic eye diseases with laser therapy can reduce the development of any severe vision losses by an estimate of 50 to 60%. So a comprehensive also foot care program can even reduce the risk of amputation by 45 to even 85%. So simple interventions at the beginning, at the diagnosis, can reduce the risk of any further complication development by a high chance. And in regards for the kidney, the pre-renal failure preventative care is first to detect and treat any early diabetic kidney disease by lowering the blood pressure, which can reduce the decline in the kidney function by up to 30 or even 70%. So angiotensin converting enzyme inhibitors and the angiotensin receptor blockers are most effective in reducing the decline in the kidney function. And without any protein intake that is greater than 20% of the energy intake, there is an association with the increased albumin excretion rate. So once albuminuria is present, then we should reduce protein to 0.8 or even 1 gram per kg per day. And if there was microalbuminuria, and we should reduce it to 0.8% or gram per kg if there was a macroalbuminuria. So each intervention depends on the current condition of the patient and their diagnosis. Also, some patients can benefit from lowering phosphorus level or their intake to 500 or up to 1,000 milligram per day. In addition, there is evidence for a benefit on renal function, glucose, lipid, and the blood pressure from weight-maintaining diets. And collaborative multidisciplinary teams are best suited to provide such care for people who have chronic conditions such as diabetes, and to also empower the patient performance of appropriate self-management. And medical nutrition therapy that is provided to the patient with type 1 diabetes and 2 has been shown to improve their glycemic outcome enormously. And the community-based education, which incorporates the social cognitive theory and the stages of change theory with 3 group sessions that is focused on meal planning and cooking demonstration is found to be effective. In addition to the education has successfully promotes the use of herbs in place of salt to prevent the development of microvascular disease, and the use of olive or canola oils to also prevent the occurrence of hyperlipidemias, and the use of artificial sweeteners in baking with the knowledge of diabetes and nutrition, and also the performance or the promotion of self-efficacy. It is also important to address any culturally specific eating habits. For example, a recent studies in South Dakota has found that the diet pattern after a historical hunter-gatherer type diet with about 25% of energy that is supplied from protein has provided better blood glucose control and a lower circulating insulin level in those who are Northern Plains Indians who have type 2 diabetes. So the same can be true for other high-risk groups. Therefore, we should address any culturally specific eating habit to avoid any uncertain complications in the management of diabetes. Another important thing to discuss in diabetes is the glycemic load or the carbohydrate counting index. So even though that there are various starches that do have different glycemic responses, the first priority should be given to the total amount of carbohydrate that are consumed rather than the source of the carbohydrate itself. So if the use of a glycemic index is proposed as a method of meal planning, then the dietitian should advise on conflicting evidence of effectiveness of these strategies. Also, studies comparing the high versus the low glycemic index diet reported a mixed effect on the A1C level. So in general, we should address the total carbohydrate intake first, and then we should focus more specifically on the types of carbohydrates that have a high or a low glycemic index and being consumed in the diet. For the nutritive sweeteners, there are some sweets or hidden sources of sugar that we should always monitor when planning the patient intervention. So this is equivalent to teaspoons. Soft drinks can contain up to 10 tablespoons of sugar, while 1 chocolate bar can have almost 6 tablespoons of sugar. So we should address these intakes in the diet to prevent a high blood glucose level from occurring due to a low source of nutritive value. While for sucrose, it is equivalent to about 4 grams of carbohydrate and can provide up to 16 kilocalories for each tablespoon. So sucrose is considered as a disaccharide and made up of 2 monosaccharide or glucose units. It is one of the sweetest sugar available, and any sucrose containing food should be replaced for other carbohydrate food, as a sucrose intake of 10 to even 35% of the total energy doesn't have a negative effect on glycemic or lipid response when it is replaced for an isocaloric amount of starch. And if sucrose is taken as a standard of 1, then the sweetness of the glucose is about 0.5 to 0.6. Also, there is no evidence that food sweetened with these sweeteners have any significant advantage on or even disadvantage over any food sweeteners that have sucrose, in which it can decrease the total caloric or the carbohydrate content of the diet, or even have an improvement on the overall diabetes control. So there is no need to focus on it. While for fructose, which is found in fruit and honey, it is considered the most sweet in taste. And even though that dietary fructose produces a smaller rise in the plasma glucose than the usual amount of sucrose and most other starches, It is not to be replaced more than 20% of the calories in adults because of its potential adverse effect on the lipid, especially the triglyceride. So there is no reason to recommend that people with diabetes avoid the consumption of fruit and vegetables in which the fructose occurs naturally. And in children, fructose work well as the substitute in any baked good because of their lipid are not yet a problem, and the fructose has little impact on the blood glucose level. In terms of herbs, there are some herbs and spices that are usually or knowing to be used for people with diabetes, and we will be discussing the most common types and whether if they are beneficial or not. So the first one is the aloe vera. As studies in Japan has found that the phytosterols in the aloe vera can play a role in lowering the blood glucose levels. But further research is needed to identify its exact impact on the blood glucose control. For the alpha-lipoic acid, the titotic acid, it can have some potential benefit on people with diabetes, as it is found in the mitochondria and seems to have an antioxidant properties which protect vitamin C, E, and the glutathione in the body. So natural sources include red meat, yeast, potatoes, and spinach. And supplementation can provide a protection against cataract, and neuropathy in diabetes, and cardiovascular disease, but also further research is needed, but a supplementation with it cannot harm the patient. For antioxidants, from food that should include good sources of beta-carotenes, vitamin C, E, and selenium in addition to zinc, all of which are considered beneficial and doesn't have any side effect or negative effect on the patient. Another common herb is the bilberry, which contain antioxidases that counteract the cellular damage to the retina. So mild drowsiness and skin rash have been noted in people who are consuming these bilberries. Therefore, they should be taken in a moderate amount and under careful control. For biotin, it shows a preliminary evidence of being useful for controlling blood glucose, and there are no known side effects for using biotin. Therefore, it can be used in people who have diabetes. For the bitter melon, which is also known as the Memoridica charentia, it has traditionally been used as a remedy for lowering blood glucose level, but there is no sufficient evidence to support their use. For chromium, it can enhance the use of insulin itself, but skin allergies, renal toxicity, and altered iron and zinc absorption can occur as a side effect. Also, there are no proven benefits if the patient is not deficient in chromium. Therefore, it shouldn't be recommended to be consumed in patients who have diabetes. For cinnamon, a dose of 1 or even up to 6 grams in a capsules on a daily basis has been found to lower the blood glucose level in individuals who have diabetes. For its essential oils, from cinnamon, cumin, and oregano, they can also enhance the insulin sensitivity in the body. But also studies are ongoing to determine their exact role or exact effect. For the evening bromose oils, it can prevent or even limit the neuropathy that is due to their presence of the gamma-linolic acid, which is an essential fatty acid. Also, it can cause headaches and gastrointestinal distress, as a side effect for consuming it. The fenugreek can also lower the blood glucose, the triglyceride, and cholesterol levels due to the presence of its psyllium. Psyllium is considered a type of fiber. We should note that it is a part of the peanut family and can cause allergic reaction to patients who have a peanut allergy. So we shouldn't, this also shouldn't be taken with any monooxidase inhibitors, as it has the potential for a drug interaction with other medication as well. So we should take careful history when assessing the patient to assess if they are taking any herbs, as some can affect the patient's condition worseningly by interacting with the medication. For the gamma-linolic acid, the evening promise oil can be useful for preventing the neuropathy in diabetes for its linoleic acid content. For garlic, which is known to be helpful in many diseases due to antioxidant properties, it can also lower the blood glucose level if it was used in large amounts, but more studies are needed to indicate its exact role or impact on the diabetic control. For the Zinoco biloba, which can control the neuropathy by maintaining the integrity of the blood vessels and by reducing the thickness of the blood and the clotting. As it has some antioxidant properties, it is considered useful in some of the cases, but we should also avoid taking them with any warfarin, aspirin, and any other anticoagulant medication, as it can have a negative impact. Also, headaches and interaction with other drugs can occur. For the ginseng, which is known to be helpful in lowering the blood glucose level, we should also avoid them when taken with any anticoagulant medication and MAO inhibitors. Also, we should avoid taking them in patients who have an extreme intake of caffeine and any antipsychotic medication, insulin, or oral hypoglycemic, because of the fluctuating in the blood glucose level, bleeding risk, and platelet functioning with blood pressure and heart rate. So we should avoid taking them also with steroid, as it can have side effects of headache, insomnia, nausea, or ministerial difficulties which can occur. Therefore, this type of herb has many complications, and we should avoid giving them to the patient. But if they were to take it, then they should take it with meals. For the guar gum, it is a fiber that normalizes the moisture content of the stool and absorbs any excess liquid in diarrhea, and also soften the stool in constipation. In addition, it decreases the amount of cholesterol and glucose that is absorbed from the stomach and the intestine. Another herb is the Gymna sylvester. It is considered as a hypoglycemic herb, and it has a highly potent and shouldn't be used only under doctor supervision, because it can change the patient's insulin requirement immediately. So some of the herbs are potent in their action or have a high effect. Therefore, they should only be used under medical supervision for assessing any alteration that is required in the insulin requirement. In addition, magnesium is needed for hundreds of biochemical reactions, which can help in regulating the blood sugar level and also the blood pressure. So some studies can suggest that a low magnesium level can have an adverse or a worse effect on the blood glucose control in patients who have type 2 diabetes. Therefore, magnesium supplementation can help with the insulin resistance, but we should avoid taking them in high doses. For turmeric, the thiazidines chorioma can also decrease the blood glucose level, but we shouldn't also take them in excessive amount. Another herb is the vandam, can also help in lowering the blood glucose level and has been associated with cancer cell growth and can be toxic at a therapeutic level. Therefore, any patient should completely avoid taking this herb. For vitamin B6, some studies have suggested that an adequate intake of vitamin B6, the pyridoxine, can help in both type 1 and type 2 diabetes simultaneously. In regard to vitamin D, a supplementation of up to 2,000 international units on a daily basis in infants were less likely to develop type 1 diabetes over the next 30 years in Finland. So this vitamin has a strong protective effect against diabetes, and experts are now recommending a supplementation at the upper end of the current recommendation level, which is 1,000 international units on a daily basis. For zinc, it is a part of the production and also the storage of insulin in the body. And fresh oysters, ginger root, lamb, pecans, and peas, all considered sources for zinc in the diet and should be recommended. Also, zinc shouldn't be used with any immunosuppressant medication with tetracycline, ciprofloxacin, or levofloxacin because of the potential of their antagonist effect. Therefore, before recommending any supplementation, we should assess their medication intake to avoid any drug and nutrient interaction. In the pre-diabetic status, it is defined as impaired glucose tolerance and distinguish those people who are at risk or at an increased risk of developing diabetes. So people with prediabetes have an fasting blood glucose or an intermittent glucose tolerance test or even both of an elevated levels, and more than 54 million Americans are affected with this combination of genes and obesity in addition to physical inactivity. So people who have prediabetes can have a family history of heart disease and can have an apple-shaped obesity, which is known to increase the risk of developing diabetes. So an elevated triglyceride and a low HDL cholesterol level are considered risk for type 2 diabetes. Also, adiposity-associated inflammation and insulin resistance are also implicated in these conditions. So the NIH has also reported that smoking can increase the risk of insulin resistance and the presence of pre-diabetic status. And under recent criteria, a normal blood glucose level is considered at 100 milligram per deciliter. Also, most people who have prediabetes go on to develop type 2 diabetes in most of the cases. This is usually within 10 years unless they make lifestyle changes. And studies have evaluated various interventions among people who have an impaired glucose tolerance and risk for developing diabetes. So the diabetes prevention program was a large prevention studies for people who are at high risk for diabetes. And half of the participants in this studies had the metabolic syndrome at the beginning of the study. And lifestyle intervention and metformin therapy reduced their development of the syndrome in the remaining participants. Also, lifestyle interventions included modest weight loss from a low-caloric, low-fat diet and an increased moderate intensity physical activity, such as, for example, walking for about 2 hours each week. So people who are treated with an intensive lifestyle intervention reduce their risk of developing diabetes by about half over 4 years. And people who were treated with metformin reduced their risk by only 1/3. So metformin is the most effective among younger and heavier people who are over or between 25 to 40 years and overweight in consideration of their BMI. So it was also less effective among older people and people with a lower BMI or who were underweight. So in the STOP in IDEM trial, the treatment of people with impaired glucose tolerance has started with drug acrobos that reduced the risk of developing diabetes by about 25% over 3 years. So the benefit of weight loss and physical activity has strongly suggested that lifestyle modification should be the first choice to prevent or even to delay diabetes. So the dietitian can play an important role in nutrition education and counseling for individuals who need behavioral change. So prediabetes also has some classifications depending on their blood glucose level values. So the condition for the classification, the first one is the impaired glucose tolerance. So the test used and diagnostic values for the oral glucose tolerance test, we should use a 75 gram of glucose for testing and a 2-hour plasma glucose level of 140 to up to 200 milligram per deciliter is considered diagnostic. For the impaired fasting glucose levels, their fasting plasma glucose should be assessed after 8 hours of fast, and the fasting plasma glucose level between 100 to 125 is considered classification. So for the intervention, the objectives first are to increase the probability of reverting from the IGT to the normal glucose tolerance and to prevent the further insulin resistance, the hyperglycemia, or even the progression to diabetes in general. We should also have a modest weight loss of up to 5 or even 10% of the body weight, and a modest physical activity of about 30 minutes daily are the recommended goals to prevent prediabetes from development. Also, walking can be encouraged for most people, and we should prevent or even delay the heart and kidney disease, stroke or eye disease, and any other undesirable complications or condition, all by having simple interventions to prevent them. Also, we should design a program which includes the element from the successful BBB trial, which include a clearly defined weight loss and physical activity goal, a flexible maintenance program, and an individual case managers for or even lifestyle coaches for each patient. Also, a culturally appropriate material and strategies depending on the patient background, and an intensive ongoing interventions for those who require more concentration, and the local with even national network of training and feedback with clinical support for the patient, with a core curriculum developed to educate the patient, and a supervised exercise sessions at least twice weekly to improve their blood glucose control. In terms of nutritional therapy, we should control, of course, first the carbohydrate intake, and only about 50% of the total calories should be from carbohydrates. We should also limit the excessive added sugars in the diet, including the sources or the hidden sources of carbohydrate that we mentioned before. Also, we should encourage less processed carbohydrate intake and fiber food sources. In addition, we should have individualized diet or dietary therapy according to the lab data and the BMI, and also the other risk conditions or reduction requirements depending on the patient's condition. Also, we should maintain protein at about 20% of the total energy intake. For fat intake, it should be no more than 35% of the total calorie, and we should encourage monounsaturated fats and omega-3 fatty acid in specific to be consumed at least on a bi-weekly basis. We should also have a low saturated fat and cholesterol, which may be needed to prevent or even to treat hyperlipidemia. So a moderate reduction in the total energy intake is also important, and a modest weight loss of up to 7% of the body weight can be recommended depending on the patient's starting BMI. Also, sufficient intake of minerals such as magnesium can be protective against diabetes, and we should include more almonds, whole wheat, and cooked spinach with baked potato and other high magnesium or magnesium-rich food. In addition, excessive of iron and selenium should be avoided, as studies have suggested that high intake can cause deposits in the internal organs, including the pancreas. We should also include adequate intake of fiber, and a low-fat vegan diet has been shown to improve the glycemia and the elevated blood lipid levels. In addition, the essential oils such as the fenugreek, the cinnamon, the cumin, and oregano can all enhance the insulin sensitivity. But as we discussed, we shouldn't add any herbs or spices until we assess their interaction with the medication. Also, cinnamon can improve the blood sugar and the lipid levels by adding half teaspoon on a daily basis. And when a tube feeding is needed, there is insufficient evidence to support the use of any specialty product as compared with the standard product at the time, but we should use a formula that has a controlled or a calculated intake or content of carbohydrates. For the common medications that are used, the carbose treatment in an impaired glucose tolerance subject can decrease the risk of progression to diabetes by about 36%. Also, metformin can reduce the risk of developing diabetes, especially among younger and heavier people, such as those between 25 to 40 years, and those who are weighting or are classified as overweight according to their BMI. Also, it is less effective among older people and people who were not as overweight as those who are. For herbs, first of all, herbs and potential supplements shouldn't be used without discussing with the physician for conversion with their medical or medication interaction. For the nutrition counseling, a community health workers can be trained for the peer counseling when administered through diabetes care centers. And lifestyle weight loss intervention has a goal of about 7% weight loss has achieved through an increase in the physical activity and also decreasing in the caloric intake with the group cognitive behavioral meetings that occurs on a weekly basis for 6 months has resulted in significant improvement in the impaired glucose tolerance. Also, a monthly small group education session for a year are recommended by the CDC, and weight loss is a key goal to control blood glucose for overweight individuals. We should also discuss the foods and meal patterns that will help to reduce the risk factors for the individualized patient. There is a trial which is called the Look Ahead trial. Their participants who were overweight and diagnosed with diabetes has exceeded the recommended intake of fat, saturated fat, and sodium, which contribute to increasing the risk of CVD and other chronic disease. So it is important to address the total fat intake, including the type of the fat in specific, and accordingly to recommend an increasement in the intake of antioxidants and rich or high fiber food. So a vegan or a vegetarian diet can be safely recommended for a diabetic patient, and we should promote 8 ounces or more of low milk or low fat milk intake, and an ounce once a day of nuts or filtered coffee with cinnamon and plenty of non-starchy vegetables, which all have been found to help in controlling the blood glucose level. In addition, exercise seems to promote a more reliable glycemic control compared with the specific dietary protocols. We should promote, therefore, physical activity which matches the patient's interests and abilities, and we should discuss how to handle the medication changes accordingly as they may require insulin adjustment. In terms of patient education in foodborne illnesses, if the patient was using or tube feeding method, then we should teach appropriate sanitation and food handling procedures. For type 1 diabetes, as we mentioned earlier, in this condition, there is an absolute insulin deficiency with total failure to produce insulin. And previously, we used the term type 1 or insulin-dependent diabetes mellitus, or even the juvenile insulin diabetes as to define it. But as type 1 diabetes involves autoimmune destruction of the pancreatic beta cells of the islet of Langerhans, then the onset often follow a viral infection such as mumps, which is usually starting in children or even young adults and affect about 10% of the cases of diabetes. Also, the beta cell damage is often more severe in patients who are diagnosed before their puberty. So what are the signs and symptoms of diabetes or type 1 in specific? The first one is polyuria, which is frequent urination, including frequent bedwetting in otherwise trained children. Also polydipsia, which is excessive thirst, and polyphagia, which is extreme hunger, is considered a sign. In addition, weakness, fatigue, irritability, and sudden weight loss are symptoms and signs of diabetes. In terms of the genetic markers, the pathogenesis for most of diabetes types is multifactorial, including both a genetic and an environmental factor. Interleukin and the HLA alleles and the vitamins D receptors gene polymorphisms can all be associated with the risk of developing type 1 diabetes. So much more research is needed to clarify how these present in the various haplotypes or ethnic groups can affect the development of diabetes. Also, the hormonal imbalance controls the key proteins that regulate the folate SAM homocysteine pathways. And the poor folate status has been associated with an endothelial dysfunction in adolescents who have type 1 diabetes. Also, the methylene tetrahydrofolate reductase, the AC genotypes of this disease, can confer the protection against early neuropathy, which can lower the homocysteine level, where a different genotype can have an earlier onset on the development of retinopathy. So the genetic backgrounds for diabetic patients can also affect the development of their complications. So the warning signs of type 1 diabetes are drowsiness with lethargy or blurred vision, extreme thirst and frequent urination, a fruity sweet or odor in the breath, and glucose or ketones in the urine, a heavy labored breathing with the child being stubborn or unconsciousness, or even sudden weight loss with increased appetite. We will be taking a break now, and then we will continue with discussing the diagnosis for type 1 diabetes. So we'll continue now with discussing type 1 diabetes. As we said, in type 1 diabetes, there is an absolute insulin deficiency with total failure to produce insulin. So type 1 involves the autoimmune destruction of the pancreatic beta cells, and the onset, in some of the cases, sometimes follow viral infections such as mumps. So the signs include polyuria, polydipsia, and polyphagia, with weakness, fatigue, irritability, and even sudden weight loss. There are also some genetic markers that are associated with type 1 diabetes, as the pathogenesis for most types of diabetes are multifactorial, including both a genetic and an environmental factor. But more research is still needed to identify how the presence of these various genotypes and ethnic group can affect the development of diabetes. As poor folate status has been associated with an endothelial dysfunction in adolescents who have type 1 diabetes. All of these can affect the genotype, which can have earlier onset of the retinopathy or even a protection against nephropathy. To diagnose type 1 diabetes, we should conduct a fasting plasma glucose tolerance test or an oral glucose tolerance test. The fasting plasma glucose is the preferred method, as a level of 126 or higher is considered to be diabetic. And with the oral glucose tolerance test, the blood glucose is measured after fasting and after 2 hours of drinking the glucose beverage that contain usually 75 grams of glucose. And the result should be between 140 to 200 in the case of prediabetes. And if it was more than 200, then this identified as a diagnosis for diabetes. Also, A1C, which is the hemoglobin A1C, is not recommended for the diagnosis, as a finger prick tests are also not valid because we need to assess the fasting blood glucose and their tolerance to glucose rather than the past for the previous 3 months blood lipids and their current or right now blood glucose level. So serious complications begin earlier than previously thought. And the glucose control really matters, as proven by the result of the CDC, the diabetes control and complication trial and other trials as well. One of the major complications with diabetes are heart disease or stroke in general, as more than 65% of people who have diabetes will die from either heart disease or stroke. So diabetes is considered the chief cause of blindness, renal failure, and amputation, and is also the leading cause for birth defects. So an intensive therapy to achieve a near normal glucose level can result in a lower onset and progression of the complications. Also, caution is needed to prevent hypoglycemia, especially in the very young children and those with any vision loss or kidney disease. So the fasting blood glucose should be measured 3 to even 8 times daily when there is the patient is starting on a new insulin regimen, as this may be tapered down when the levels are stable and the patient's condition has stabilized. Also, the protein and the nutrient metabolism are affected by insulin availability and therefore should be monitored as well. For the long-term effect of diet that is high in protein and low in the carbohydrate, they are still unknown, but they can produce a beneficial effect over the short term. So vitamins and mineral intake are also being studied for their various impact on the blood glucose levels. In addition, it is important to know that antioxidant food and spices can be helpful in lowering the blood glucose level, but these should also be monitored carefully for any adverse effect or medication-nutrient interaction. For individuals who are using insulin, they should eat at a consistent time that is synchronized with the time of action of the insulin preparation that is being used. We should also monitor their blood glucose level and determine their required insulin doses for the amount of food that is usually eaten. We should also intensify the insulin therapy, including multiple daily injection with continuous subcutaneous insulin infusion with an insulin pump, and also a rapid-acting insulin, which can allow for a more flexibility in the timing of the meals and snack, as well as in the amount of the food eaten itself. For the medical costs for patients who have diabetes, it accounts for a significant percentage of all of the healthcare costs. And the national standards for diabetes self-management have been written to support a team of approach for patient care, as they can include the dietitian as an essential team member and an ongoing nutrition self-management education, including assessment, care plan, and the treatment goals, and also monitoring for the metabolic parameters such as blood glucose, lipid, and A1C is always recommended. In addition, the use of an evidence-based medical nutrition therapy can lead to effective lifestyle changes. And the use of technologies to track the quarterly weight and the lab value is effective to help the patient with their self-management goals. In addition, the multidisciplinary team intervention are suggested to help improve the patient A1C levels and also to reduce the complications, the hospital readmission, and the hospital stays. And the American Dietetic Association recommend a specific number of MNT visits to promote the desirable outcome. For the intervention, we should individualize the MNT as needed to achieve the treatment goals, and preferably provided by a dietitian that is familiar with components of diabetes. So the recommended medical nutrition therapy visit for type 1 diabetes are at least 8 encounters from the diagnosis time. Each should be presented within at least the first year of diagnosis. So between the first and the second visit, this should be between 2 to 4 weeks maximum, and we can increase the length between the visit after the 5th visit as the patient has adapted or has more knowledge in controlling their diabetes. Also, we should address the metabolic abnormalities of glucose, the lipid, and blood pressure, and we should meet the specific needs of the patient and modify the drug therapy to enhance the outcome and also the quality of life. We should, in addition to this, regularly evaluate the food and nutrition history, the physical exercise, the activity pattern, and the weight gain in particular. We should also develop a food and meal planning with the patient and share this meal plan with the medical team so that the insulin regimen can be integrated into the client's usual lifestyle and adjusted accordingly. And in hospital setting, we should avoid the use of a restrictive diet to enhance the patient appetite and consumption of food. We should also promote lifestyle changes according to the patient readiness and educational level with their skill level. We should also have early referral for lifestyle changes, and the advices that yield most benefit are the ones that is started or implemented early on. For meal planning, we should develop the meal along with an exercise and medication goals to achieve the blood glucose and required levels. We should also minimize the intake of trans fatty acid, saturated fats that should be at least or maximum 7% of the total caloric intake. So in addition to monitoring the total intake of fat and carbohydrate, as we mentioned, we should also monitor the specific constituent of the fat and the carbohydrate itself. We should also prevent early onset of complications by controlling the glucose, lipid, and blood pressure levels. And if there are any complications, we should delay or even prevent their consequences and complications. Also, the DCCT intensive therapy group had substantially lowered the complication rates, and there is less than 1% became blind and required kidney replacement or even had amputation because of diabetes. So all of these implants or recommendations can be helpful, as we mentioned, in preventing any future complications depending on the patient condition. So both the amount of carbohydrate as well as the type of carbohydrate in the food can influence the blood glucose level. Therefore, we should monitor the total grams of carbohydrate which remain a key strategies in achieving the glycemic control. And afterward, we should divide the meal or look more closely at the meal to see what type of food have a higher glycemic index and should be avoided. In addition, we should teach individuals on how to use carbohydrate counting and how to adjust insulin doses based on a planned carbohydrate intake. We should also promote self-monitoring of the blood glucose on multiple times per day and more often during the illness period, as this can affect their glucose level. For medical nutrition therapy, a meal plan that is based on the individual usual food intake should be used as the basis for an integrating insulin therapy into the usual eating and exercise pattern. We should also choose a variety of heart-healthy food, including an average of 5 servings of fruit and vegetables with 6 servings of grains, that is 3 whole grains, and also 2 servings of low-fat dairy products. The dairy products can help in maintaining a normal glycemia for a certain amount of time, especially this is recommended before sleeping as to have a better glycemic control overnight. So food in the meat and the fat group doesn't directly affect the blood glucose level, so we should discourage meal skipping and determine an appropriate energy intake for the age of the patient. And for pregnant and growing individuals, they should receive more caloric than the usual. For example, a sedentary person will receive 25 kilocalories per kg, while a normal person of a normal activity will receive 30 calories. and an undernourished or even an active person would receive up to 50 calories per kg. Therefore, we should reassess the physical activity level or their life stage changes, such as in children or in pregnant women, depending on their condition. Therefore, it should be reassessed and reevaluated on a regular basis according to the patient. Also, monounsaturated fatty acid and carbohydrates that is combined should provide 70% of the daily energy intake. Therefore, we should also limit the saturated fat to 10% of the energy intake specifically. And we should use a plan that includes carbohydrate at about 65% of the total energy intake each day to prevent the occurrence of ketosis. We should also apply carbohydrate counting, dietary guidelines, or My Pyramid food guidance principles when developing the meal diet. And we should also focus on on the carbohydrate more than the total energy or the source of the carbohydrate in specific. In addition, we should determine the insulin to the carbohydrate ratio for each individual depending on their units of insulin. So 1 carbohydrate unit is equal to 15 grams of carbohydrate of the standard starch, fruit, or even milk serving. And this is corresponded to 1 unit of insulin. So each 15 grams of carbohydrate is equal to 1 unit of insulin. So for carbohydrate, it provides a consistent carbohydrate with each meal and snack with a set dose of insulin, as this will have the better outcome in glucose control. So each of the following portions is 1 carbohydrate in serving. For example, a slice of bread or cereal, which is approximately half a cup of cooked or dried cereals, and third cup of starch, all are equivalent to 15 grams of carbohydrate. While for dairy products, for example, 1 cup of milk is equal to 1 serving of carbohydrate. And for fruits, 1 small fresh fruit is equivalent to 1 serving of carbohydrate. And any snack, for example, pretzels, 34 ounces, is equal to 1 serving of carbohydrate. And for vegetables, half a cup of cooked vegetables is equivalent to 1 serving of carbohydrate. So as you can see, some portions will be more fully to the patient and will satisfy them and have a lesser content of carbohydrate. Therefore, it will have a better outcome in their glycemic control and should be incorporated more often in their diet than others. So most women will need about 3 to 4 carbohydrate choices at each meal, and men generally need about 5 carbohydrate choices per meal. And an active young woman would approximately need about 2,500 calories or about 90 gram serving of carbohydrate, where a young active woman, a man can need up to 3,000 calories, which is equivalent to 100 gram of carbohydrate. We should use about 1 to 2 carbohydrate choices for snacks only, depending on the patient's body size and their activity level. That will determine the number of choices. We should also include plenty of fiber from rice, beans, and vegetables that will help in maintaining a normal glycemia to some degree. So the recommendations for fiber intake for people who have diabetes are similar to the recommendation for the general population. This should be about 14 grams of carbohydrate of fiber, for each 1,000 kilocalories. And if the diet contains 50 grams of fiber, this will result in a better improvement in normalizing the glycemic level. Also, whole grains are a good source for vitamin E, fiber, and magnesium, and should be consumed or added in the diet. In regard to protein, to reduce the risk of a nephropathy, the protein intake should be limited to the recommended dietary allowance. And if there is microalbuminuria, a more controlled protein intake will be required. So a cut down or even an elimination of the fried food and creamed food is recommended. And we should include omega-3 fatty acids, such as from salmon, to control the blood levels and to reduce inflammatory processes. Also, a high monounsaturated fat diet seems to have a favorable effect on lipoprotein in diabetes. And for minerals, we should assure the adequacy of intake on protein supplementation that is often not recommended, but we should have regular supplementation of vitamin and mineral. We should also replenish the potassium and magnesium if it was needed. And an adequate calcium is important with up to 500 milligram dose in 1 to 3 years old and can reach up to 1000 milligram in adults that should be taken daily. And for sodium intake, it should be limited to 2400 milligram on a daily basis or even less if possible. In addition, a routine supplementation with antioxidant vitamin E and C with beta carotene is not advised because of the lack of evidence for its efficacy. Also, folate is important in women of a childbearing age, and this can require 400 grams in pregnancy, before pregnancy, and 600 grams during pregnancy. Also, vitamin D has been found to play an important role in an autoimmune disease. Therefore, we should encourage the intake of vitamin D fortified food, but also we should encourage adequate time in the sun exposure to enhance their vitamin D levels in natural ways. And if the foods that are containing sucrose are chosen, then they should be substituted for other carbohydrate food, as we have discussed earlier that sucrose increases the blood sugar level as it has a high glycemic index value. So a sucrose intake of 10 to even 35 of the total energy doesn't affect on the glycemic or lipid response negatively when it is substituted for an isocaloric amount of starch. Also, non-nutritive sweeteners are safe when they are consumed within the acceptable daily intake level that is established by the FDA. In regard to physical activity, adequate carbohydrate replacement during or after exercise is important to prevent the occurrence of hypoglycemia. We should also decrease the rapid-acting insulin doses during the physical activity, and up to 50% reduction is reasonable choice. In regard to critical illnesses, during a critical illness or a stress state, the blood glucose management is a challenge. As intra-feeding is generally preferred, but a specialty formula are not usually required in most of the cases. This depends on the patient's condition. And regular blood glucose monitoring with insulin replacement can be needed in some of the cases. Also, if parenteral nutrition is needed, then we should use a strict blood glucose control. In addition, hyperglycemia can reflect illness severity and can result also in deteriorating skin sequences. We should therefore plan 30% of nutrient intake as fat and 50% as carbohydrate and about 20% as protein unless they have other disease status that require alternative plans such as cardiovascular disease or renal disease. In terms of medication, an anti-CD3 MABs can prolong the beta cells function up to 2 years in patients who have a new onset of type 1 diabetes, but studies are still ongoing to assess the effectiveness of this medication. Also, correlation of the insulin and the diet is essential to determine if there need to be any adjustment in the insulin dose or in the dietary plan. And for persons with type 1 diabetes, they are usually dependent on insulin for life, and the primary potential effect is hypoglycemia for insulin. So the sources of insulin must be noted because they can affect the peak times and also the duration of effect and can have some effect on the speed of the absorption. The human insulin is produced synthetically from the Eicosanolia coils or yeast who has identical amino acid sequence to the human insulin that is present. So an insulin pump that is continuous subcutaneous insulin infusion can be a good choice to maintain the glucose level. And if a pump is used, then meal scheduling are not as strict but shouldn't be abused. And with multiple daily insulin injections, test blood glucose before the meals to determine the insulin dose unit that is required. Also, the insulin pens available are the convenient for insulin dosing and the best choice. And then insulin glargine, which is lactose, is well tolerated in the MDI regimen for pediatric patients who have type 1 diabetes and can also be more efficacious than the MBL lentil in those who have an elevated or high level of A1C. So the insulin analogs can match the postprandial blood glucose exertions better than the traditional insulin. And the bolus angelos are usually for more rapid insulin onset to cover the meal carbohydrate and also to correct the hyperglycemia immediately. And the basal agent can be released at a more consistent rate to cover the between meal glucose needs or the body basal insulin need. So a pre-mixed insulin are discouraged except when the patients are not able to be complemented with MDI. So choosing the insulin type depends on the patient condition and also their compliance. So the adverse effects can include the potential for hypoglycemia, especially when the A1C level is less than 7%. And the analogs insulin are less likely to lead to hypoglycemia, especially during overnight hypoglycemia. And also weight gain with the use of insulin can be counteracted with attention to food intake and also to physical activity. In regard to herb, they shouldn't be used without discussing with the physician first. And as we said earlier, some of them can have an adverse effect on the medical condition or even worsening of the side effects. So there is still insufficient evidence to draw a definitive conclusion about the efficacy of beans, peanut, onions, and aloe vera on the glucose control. So adequate vitamin D should be available, especially for bone health, as this is the only recommended supplement for patients with diabetes. For nutrition counseling and management, the dietitian should assist the food intake, focusing especially on the carbohydrate. Also, they should assist the medication, metabolic control, such as the glycemia and lipid profile with the blood pressure, and anthropometric measurement with physical activity should be assessed to serve as the basis for the implementation plan of the nutrition prescription. Also, the intervention should be tailored to the individual need. In addition, diabetes self-management education is an essential element for the diabetes care, and the national standards have been based upon this evidence, as teaching the patient how to manage their insulin themselves will have a more beneficial effect on their long-term health outcome. So DSME can help the patient in optimizing their metabolic control, preventing and managing the complication, and also maximizing the quality of the life in the cost-effective manner. Also, learning can lead to behavioral changes such as healthy eating habits with better activity levels and taking their medication, with monitoring the glucose and problem-solving skills, all of which can lead to a desirable clinical and health outcome and probably the prevention of the long-term complications or side effects. So overall, an improved health status, including better quality of life, a fewer days lost from school or even work due to sick days, and fewer complications with healthcare costs are all preventable with appropriate management. In addition, weekly problem-based self-management support intervention can have a better health benefit, as can even one single session with the dietitian. So we should teach the patient about the importance of self-care, optimal functioning, the roles of carbohydrate intake, and also physical activity in maintaining metabolic control. An important assessment is always the blood glucose testing or level, and the insulin injections must be given at planned regular intervals for patients who have type 1 diabetes. We should also identify the potential or the real obstacles and discuss the options for resisting temptation, dining away from home, and feeding deprived with time pressure and food offers from others, all of which can have better outcome on the patient tolerance. Also, we should encourage regular meal times and snacks to avoid the occurrence of hypoglycemia. In addition, children and teens in particular can need a planned snack timing to prevent the development of hypoglycemia. Also, a non-diet approach to diabetes management can encourage regular eating according to the actual hunger cues and making a gradual changes for the healthier eating. We should also discuss the visual assessment of portions and practice with measuring cups, spoons, and scales to help the patient better understand how portions occur. Also, we should teach the patient how to read labels and also how to identify carbohydrates in the processed food. Also, empowering the patient is important as it can help the patient in gaining a mastery over their affairs and to have an effective change on their health in general. We should therefore discuss the emotional eating, such as from boredom, anger, or frustration, and even depression. We should have alternative choices that is designed from the client's perspective or preference to better have tolerance. As research report has sustained improvement in A1C level at 12-month period and even longer when a long-term follow-up encounters with the dietitian. So regular visits can help in improving the patient compliance to the regular dietary intervention. We should also discuss the weight gain that occurs with an intensive insulin therapy and the improved glycemic control. Also, a low carbohydrate diet are not recommended for the management of diabetes, but they should have a sufficient carbohydrate intake rather than a low one. We should also discuss the risk for CVD and how to manage them. And eating disorder often can occur in young women who have diabetes. Therefore, if needed, they should be referred to a psychologist. Also, A1C is often unacceptably high in adolescence, and there is a need to have a more fully assessment and understanding of the factors such as race and ethnicity with education and their socioeconomic status on the treatment recommendation to have a better management. And during the sick day, that can increase the stress on the illness. The patient can require more insulin when they are sick. Also, liquid diet should provide about 200 grams of carbohydrate in equally divided amounts at meal times and snacks, as liquid shouldn't be sugar-free at all. So, a 200 gram of liquid diet is a 200 gram of carbohydrate in a liquid diet should be divided across the whole day. And for surgery, the blood glucose should be in a good control during the preoperative, as hyperglycemia can be managed with doses of short-acting insulin. Also, correct abnormalities before the surgery, if possible, to avoid any surgical complications. And we should discuss the reasonable use of the glycemic index. And we should aim for about 30 minutes per day of physical activity to burn a minimum of 1,500 calories in a day. So we will be taking a break now for Al-Maghrib prayer, as then we will continue with discussing the islet cell transplantation as a treatment method for diabetes. السلام عليكم ورحمة الله. Welcome back everyone. بالنسبة للي كانوا بيستفسروا عن مدة البريك، يعني فضلا الأخذ بعين الاعتبار أن الحضور من جميع أرجاء المملكة، فوقت الصلاة في مدينتك أخي الفاضل مختلف عن وقت الصلاة في المدن الأخرى، فإحنا بنحاول ناخذ وقت بحيث يكون في المنتصف والكل يقدر يؤدي صلاته. ولو في أي استفسارات إن شاء الله في النهاية عندنا ديسكشن تقدروا تعلقوا على أي حاجة في الدورة ونسأل ونتناقش في المحتوى إن شاء الله. الله يعافيكم، بالتوفيق. So now we will continue with discussing islet cell transplantation, which is a mechanism for treating diabetes in some of the cases. So first of all, some native pancreatic beta cell function that persists even years after disease onset in most of type 1 diabetic patients is present. And nonetheless, the destruction of these beta cells can lead to permanent insulin dependence. So islet cell transplantation can lead to insulin independence with excellent metabolic control over time. So islet transplantation can require more than one donor pancreas to achieve insulin independence. Also, transplant may be performed by either a radiologist who uses X-rays and ultrasound to guide the placement of catheter through the upper abdomen and even into the portal vein, while the islets are slowly infused. So if this is not feasible, a surgeon can perform the procedure under anesthesia. So depending on the patient's condition, this can be a simple procedure performed by a radiologist or a more serious surgery performed by a surgeon. So the acute post-transplantation phase can last up to 2 months. And the chronic phase can start after 2 months of the diagnosis. So medication are needed to prevent the rejection after transplantation, which is the simple guidelines after transplantation of any organ. So islet cell programs try to avoid using large doses of glucocorticoid, and most protocols are designed to use the tacrolimus and the sirolimus so that a high dose of glucocorticoid would not have to be used. So it will be the last choice. And during the acute period of care, there is issues of the patient who are variably managed with insulin therapy to allow for the recovery of the islet after they have been placed into their new and not totally adequate environment in the liver. So most centers treat patients for up to 1 month, and treating the hypoglycemia during this time is a concern and must be managed appropriately depending on the severity of the case. Also, long-term complications can include hyperlipidemia. And in type 1 diabetes, the release of many hormones, not only from the beta cell, but also from the adipocyte, is altered and not that similar to the regular or healthy individual. بالنسبة للأسماء مرة واحدة ترسل وليس بعد كل بريك. So after successful pancreas and kidney transplantation, type 1 diabetic patient can revert to a non-diabetic metabolism, so they become healthy to some degree. So the altered adipokines are still present after the BKTX transplantation, and the adipokines include the vesperine, the retinol binding protein, adiponectin, and also the high molecular weight adiponectin. So more research in this area is needed, but it is considered as a successful treatment option for some of the cases. The clinical indicators for islet cell transplantation. So these indicators must be present to determine which patient will receive the transplantation. So for the objectives, the patient should meet the specific need, and we should modify the drug therapy to enhance the outcome and also the quality of life. So we should also prevent infection and promote healing, and we should monitor for any abnormal electrolyte levels. Also, we should monitor for carbohydrate intolerance, but we should make sure that the diet provides enough carbohydrate to spare protein from breaking down. Also, treatment goals should reflect those of the American Diabetes Association, and we should adjust them as the new guidelines or evidence suggest. We should also elevate the rejection episode by using antibiotics, and we should control infections, especially during the acute phase. We should, in addition to that, support protein intake to prevent any additional infection. In addition, we should force the fluid unless it is contraindicated, as it can be in the cases of retentions, and we should match the fluid output to the input, and we can help the patient adjust to lifelong medical regimen during their chronic phase. We should also improve the survival rates by supporting the immune response, and we should correct or manage the complications that occur in response to any intervention. Also, we should control the weight gain in the first year after the transplantation. For the medication that are used after the islet cell transplantation, the first one is the cyclosporine. It doesn't cause any retention of sodium as much as the corticoid does. Also, intravenous doses of this medication are more effective than an oral dose, and the side effects can include nausea, vomiting, and diarrhea. Possible side effects also include hyperlipidemia, hyperglycemia, and hyperkalemia. So therefore, we should decrease the fat intake as well as sodium and potassium if it was necessary when we start this treatment. Also, magnesium may need to be replaced, and this medication is also considered as nephrotoxic. Therefore, a controlled renal diet may be beneficial to reduce the load on the kidneys in general. We should also recommend the patient take omega-3 fatty acids to reduce the toxic side effects such as high blood pressure and kidney damage. Another medication that is used after islet cell transplantation is diuretics. This can be such as Lasix, which can cause hypokalemia. And aldocaton actually spares the potassium, and therefore we should monitor the drug changes closely to make the necessary adjustment depending on the patient response. So in general, we should avoid the use of fenugreek and yombi and ginkgo, which are all herbs that are being used by some diabetic patients. Therefore, we should recommend that they avoid it. For immunosuppressants such as Mobrain, which is the orthocolone, and the anti-thymotic globicon are less nephrotoxic than others, such as the cycloprotein, but these can also cause nausea, anorexia, diarrhea, and vomiting. Therefore, with any medication, we should monitor the side effects and manage them accordingly. Also, fever and stomatitis can occur, but therefore we should alter the diet as needed depending on the symptoms development. For insulin, it may be necessary during the periods of hyperglycemia after the transplant in a short period of time. Also, we should monitor for hypoglycemic symptoms during the use of insulin, and we should teach the patient to self-monitor or self-management tips. Pancreatic enzyme can be needed if the pancreatitis occur after transplantation. So if they were used, then we should manage them accordingly. And for the tetranectine, it can bind to the plasmaglobin, which can have a role in regulating the periocular proteolysis and also in the survival of the isolate after transplantation in the liver. So each medication can have possible side effects, therefore we should monitor them closely and make the necessary adjustment depending on the patient response to the treatment. For nutritional therapy, we should progress with the patient to solid food as quickly as possibly post-operatively, and we should monitor the fluid status and adjust them as needed. Also, a daily intake of protein should be appropriate for the age and the gender, and 1.5 gram per kg while the patient is using steroid can be recommended as a starting point. For energy need, it should be calculated as 30 to 35 kilocalorie per kg, as the patient is an increased metabolic status after the surgery. And a daily intake of sodium should be between 2 to 4 grams until the drug regimen is reduced. We should also adjust the potassium level as needed. In addition, a daily intake of calcium should be between 1 to 1.5 times the daily requirement to offset the poor absorption. And the children especially need adequate calcium for their growth. Therefore, we should ensure adequate intake. In addition, a daily intake of phosphorus should be equal to calcium intake, and we should supplement the diet with vitamin D, magnesium, and thiamine as needed. Also, adequate vitamin intake will be essential to maintain the immunity and support wound healing after the surgery. Therefore, a multivitamin supplement can be indicated for some of the patients. We should also control carbohydrate intake with hyperglycemia, and no more than 50% of the total calories should be from carbohydrate, and we should encourage healthy food sources for carbohydrate, such as food that is rich in fibers rather than food that is have a higher content of sugar. So transplantation patients are considered at risk for further glucose intolerance from the use of multiple medication. And we should blend fat at about 35% as a maximum of the total calorie, and we should encourage the intake of monounsaturated fat, especially and omega-3 fatty acid. Also, low saturated fat and cholesterol may be needed depending on the patient condition, and a controlled fat intake is recommended for the prevention and also the treatment of hyperlipidemia. We should also reduce the gastric irritants such as that are necessary if there was a GI distress or even gastric reflux. In addition, we should monitor the electrolyte carefully, as hyperkalemia is common with the cyclosporin or tacrolimus, depending on the medication that is being used. So hyperkalemia must be monitored in those patients. In addition, special diets may be discontinued when the drug therapy is reduced, to the maintenance level if necessary. And we should encourage exercise and weight control plan thereafter to prevent the occurrence of any further complications. For the use of herbs, it shouldn't be used after transplantation, and their use must be discouraged. So those patients who self-medicate with herbs, who are taking a chance in their use of herb, can have an interaction with their immunosuppressive medication. Therefore, this can either cause a higher or even lower than the desired drug level of these agents, and we should take careful history from the patient to know if they are using any herbs or spices. One of the medication or the herbs that are mostly used by the patient are Chabral, which is a herbal product that can cause severe hepatitis or even liver failure. Also, St. John's wort interferes with the metabolism of any immunosuppressant and shouldn't be used after transplantation. Therefore, a simple intake of herb can have a severe adverse effect on the patient outcome after the transplant. For nutrition education and counseling, we should indicate which food are the sources of key nutrients such as protein in the diet. Also, if the patient doesn't like milk, we should discuss how other sources of calcium can be used in the diet to have a better calcium intake or absorption in general. Also, patients should know when to seek any medical attention if they had any minor complications or major ones. We should also discuss the problems that occurs with long-term obesity and hypercholesterolemia, and therefore we should encourage moderate weight loss depending on the patient's starting weight. We should also encourage moderation in the diet and promote adequate exercise, also depending on the patient's physical condition. For food-borne illnesses, in terms of patient education, if the patient was using tube feeding, then we should teach the patient on appropriate sanitation and food handling procedure to prevent the occurrence of any food-borne illnesses complications. After discussing pre-diabetes and type 1 diabetes, now we will start with discussing type 2 diabetes in adults. So, as we mentioned previously, type 2 diabetes arises because the body has insulin resistance. And when there is a failure to use insulin properly, then this should be combined with the relative insulin deficiency. Also, an increased and unrestrained hepatic glucose production, as well as diminished glucose uptake and utilization, can result from insulin resistance that occur in the cells of the liver and also other peripheral tissues, especially the skeletal muscles. Some of the previous names or terms for type 2 diabetes include non-insulin dependent diabetes, adult onset, type 2, or mature onset, and also ketosis resistant diabetes. So type 2 diabetes occurs for about 90% for all types of diabetes. So it is the most common type of diabetes mellitus. And a significant percentage, about 1/3 of the individuals who have type 2 diabetes, are unaware of their diagnosis. This is due to the fact that type 2 is progressive and most patients will have already lost about 50% of their beta cell function at the time of diagnosis. So the American Diabetes Association recommends diagnostic screening at 3 years interval, beginning at the age of 45. This is done to detect the occurrence or the presence of type 2 diabetes from the start to therefore avoid any certain complications. So there are some risk factors for type 2 diabetes, including genetic, obesity, age, and history of gestational diabetes with sedentary lifestyle and also smoking. So smoking cessation alone and decreasing BMI with decreasing the blood pressure accordingly are considered a major modifiable risk factor that are also major determinants of the acquiring of type 2 diabetes. So a person who is a smoker and obese will most likely have hypertension. Therefore, if they modify these 2 or 3 factors, they will have a better outcome of their diabetic health. Also, for reducing blood pressure, there are numerous clinical trials and expert support that reducing the sodium intake and modest weight loss with increasing the physical activity in conjunction with a low-fat diet that include fruit, vegetables, and low-fat dairy products with moderate substance abuse can reduce the risk for type 2 diabetes and reduce blood pressure. So medical nutrition therapy from dietitian in the treatment can improve the glycemic outcome with decrease in A1C of the approximately 2%, depending on the duration of diabetes. Also, early referral for lifestyle changes and advice will yield the most benefit on the patient health. So the body first defense against invading pathogens or tissue injury is the innate immune system. So the chronological anti-inflammatory pathway is a neural mechanism which suppresses the innate inflammatory response, such as excessive cytokines release in type 2 diabetes. So the use of antioxidant food and spices and the Mediterranean diet in specific has shown positive results as compared with a low-fat diet. So patients should be educated about the progressive nature of diabetes and also the importance of the glycemic control with appropriate food choices and physical activity in association with anti-diabetes medication. So we should maintain focus on lifestyle strategies that will improve the blood glucose, the blood pressure, and also the lipid levels. In addition, diabetes self-management training that consists of 4-hour class followed by individual dietitian consultants with a monthly support meeting can lower the A1C level at a very low cost compared with the following complication if this wasn't managed appropriately. So in specific, weight management is very helpful. And the addition of a modest cost RDA yield lifestyle case management intervention to the usual medical care doesn't increase the healthcare cost and can yield a modest cost saving among obese patients with type 2 diabetes. In addition, weight loss can significantly reduce diabetes costs. For every 1% of the weight loss, there is about 4% saving in the total healthcare cost and 6% saving in the diabetes care cost. So even a slightest change can result in a tremendous benefit for all. And the American Dietetic Association recommends for MNT visit initially then one visit every 6 to even 12 months, depending on the patient's compliance. Also, referral to dietitian within the first month after diagnosis is important so that the patient would know how to manage their diet appropriately. There are also some risk factors for type 2 diabetes. These include age, which is older than 45 years, and some certain ethnic groups are at more risk, such as African American, Hispanic American, Native American, Asians, and also Pacific Islanders. Also, if we have a family history who's a parent or a sibling with DM, even type 1 or 2, this will increase the risk of developing type 2 diabetes. In addition, a habitually sedentary lifestyle can increase the risk of type 2 diabetes. And a high-density lipoprotein cholesterol level of 35 milligram per deciliter with triglyceride level of 250, this is considered a risk factor for type 2 diabetes. In addition, if a female has a history of gestational diabetes or a woman who delivered a baby whose weight is more than 9 pounds, then this puts the female at a higher risk for developing type 2 diabetes. Another risk factor is a history of impaired fasting glucose or impaired glucose tolerance. In addition, hypertension, which is a blood pressure of 140/90, can increase the risk of developing type 2 diabetes. Also, a patient who's obese and their BMI is more than 25, this puts them at an increased risk for type 2 diabetes, and patients with polycystic ovarian syndrome and other conditions that are knowingly associated to be causing insulin resistance can also increase their risk and the risk of vascular disease. For the intervention, first of all, we should provide the persons who have diabetes with initial basic nutritional messages and schedule time for their medical nutrition therapy, and with someone who has expertise in diabetes management. So we should maintain or aim to maintain a near normal blood glucose level as possible by balancing the patient's food intake and their insulin doses. Also, their oral glucose lowering medication should be taken into account with also their activity level when managing or developing a dietary plan for the patient. So improvement with medical nutrition therapy, if successful, is usually seen within 6 weeks up to a maximum of 6 months after the patient's commitment to the treatment. And medication can be needed if the blood glucose levels are under control. Also, we should maintain the A1C levels at 7% and not more, and the pre-pharyngeal capillary plasma glucose level between 90 and 130, with the peak post-pharyngeal capillary plasma glucose at 180. So the target goal range for the patient may vary by the age and underlying disorders. بالنسبة للاستفسارات فضلا جهزوها وكلها إن شاء الله آخر محاضرة اليوم حنناقشها. So we should protect the beta cell function by controlling hyperglycemia, and A1C test should be done at least 2 times a year in patients who are meeting the treatment goals, and even quarterly in patients whose therapy has changed or who are not meeting their glycemic goals. Also, we should aim to achieve optimal serum lipid levels to reduce the risk for macrovascular disease. And this lipidemia is a central component of insulin resistance in all ethnic groups and should be monitored carefully. So, emphasis of the medical nutrition therapy on lifestyle strategies to reduce glycemia and dyslipidemia with the blood pressure is important. And strategies should lead to reduced energy intake and increased energy expenditure through the physical activity. So the A to Z, which is the Atkins to the zone diet, weight loss diet analysis, found that a premenopausal overweight and also obese women who followed the Atkins diet, which is a diet very low in carbohydrate, similar to the keto diet, those women has lost more weight at 12 months than women who are assigned to follow the zone diet. So for some patients, a low carbohydrate, high protein, high fat diet can be feasible as an alternative recommendation for weight loss technique. We should also maintain or even improve the overall health and the dietary guidelines for the Americans, and the My Pyramid Food Guide can illustrate healthy nutritional guidelines which can be used by people who have diabetes. Also, we should encourage regular mealtime and maintain lifestyle changes through behavior modification, education, and problem-solving strategies. Also, we should address the individual needs according to the culture, ethnicity, and lifestyle while respecting the willingness to change for the patient. And for older patients, we should meet the nutritional and psychosocial needs for them as well. In addition, for pregnant or lactating women, we should provide adequate energy and the nutrient for optimal outcomes, and we should encourage therapeutic lifestyle changes considering the patient's readiness skills, their resources, and their current needs. We should also aim to achieve blood pressure levels that reduce the risk of vascular disease and also renal function decline. And we should manage the problems that are related to compulsive or binge eating. In addition, patients often report deliberate omission of insulin or even oral hypoglycemic agent in an attempt to lose weight. Also, we should manage children who have type 2 diabetes or maturity onset diabetes of the youth differently than those who have type 1 diabetes. For nutritional therapy, the dietitian should calculate the carbohydrate and also fat requirements individually according to the patient's lipid and glucose levels. We should therefore assess the dietary history, the physical exercise, and the activity pattern for each patient individually. In addition, we should include food containing carbohydrates from whole grains, fruit, vegetables, and low-fat milk, as the first group can contain high fiber content, which can help in maintaining a normal glycemia. Also, a vegan diet is an effective consideration for some of the patients, and even moderate weight loss in an obese patient in about 10% of their starting weight can reduce the hyperglycemia, the dyslipidemia, and also hypertension. Also, a moderate caloric restriction of about 250 to up 500, less than the average daily intake from the food history. This can result in a considerable reduction and control of blood glucose. So a nutritionally adequate meal plan should be recommended. And an extremely low carb diet or low caloric diet for adults should be performed only in a hospital setting under carefully controlled conditions. And in morbidly obese patients, a bariatric surgery can be the only effective treatment if they have severe hyperglycemia and inability to control their dietary intake. So there are risks from the surgery, of course, and anesthesia, but the benefit often outweighs the risk. We should also space the meals and spread the nutrient intake, in particular the carbohydrate, through the day to maintain a somewhat normoglycemic control over the day. Also, eating breakfast has beneficial effects on the fasting lipid and the postprandial insulin sensitivity. Also, we should advise the patient to avoid skipping meals as this can result in hypoglycemia or even overeating at the next meal, which will lead to hyperglycemia. Also, individualized meal planning according to the patient preference is recommended always. And carbohydrate should be calculated at a percentage between 45 to 65%. In addition, consistency is very important as this will help in maintaining the blood glucose levels. In addition, protein should be calculated at 15 to even 20% of the daily energy intake with normal renal function and control at 0.8 to even 1 gram per kg with renal disease. And where weight loss is needed, we should use a diet that is slightly higher in protein, which can help to enhance insulin sensitivity. And for fat intake, it should be between 25 to 35% of the energy intake. And from that, up to 10% of the caloric from the fat should be from saturated fat, and 10% should be from polyunsaturated fat, with 15% from monounsaturated fat. Also, we should limit the intake of cholesterol to about 300 milligrams per day. In addition, food that benefit both the carbohydrate and the lipid abnormalities should be consumed often. And recommendations are the same for the general population concerning the fiber intake, and people with diabetes should use more of brown rice, beans, and green leafy vegetables, which are high in their fiber content and can maintain a normoglycemia. And as a part of a healthy lifestyle and management of hypertension, we should teach the patient about the DASH diet principles, which is a diet that is specifically designed to stop hypertension. Therefore, the sodium intake should be no more than 2,400 milligrams per day. And for most vitamins and minerals, we should ensure adequate dietary intake for all individuals. In addition, a higher level of magnesium, chromium, and zinc are recommended, and a multivitamin mineral supplementation can be used. And because of the altered vitamin D and calcium homeostasis, which can play a role in the development of type 2 diabetes, a supplementation of both can prevent type 2 in high-risk population. Also, vitamin K as a phytoquinone can also have a role in glucose management and therefore should be recommended to be used. We should also discuss the usefulness of artificial sweeteners and food diaries with the patient to manage their condition appropriately. For medications, as type 2 is a progressive disease, medication will need to be combined with a lifestyle strategies. And insulin may be used in combination with oral therapy or alone, depending on the patient's condition. If the patient was using oral glucose lowering medication that is not achieving a normoglycemia, then this will be combined with oral therapies of 2 or more drugs that can be initiated depending on the patient's response to one treatment. Also, if combination oral therapy doesn't work, then insulin injections are needed. So insulin may also be needed for refractory hyperglycemia in the case of diabetic ketoacidosis, in cases of stress also, infection, or during pregnancy. So multiple drug therapy is generally required to achieve blood pressure targets also. And ACE inhibitors treatment and angiotensin receptors blockers with beta blockers, diuretic, and calcium channel blockers can all be helpful for some of the patients. And aspirin therapy is recommended to protect against the development of cardiovascular diseases. And there is evidence that suggests that a renin-angiotensin system can play an important role in the pathogenesis of DM and its associated cardiovascular risk, as these blockers can delay or even prevent the onset of type 2 diabetes. So in individuals with diabetes over the age of 40 and without any overt CVDs, then statin therapy to achieve an LDL level of 100 is recommended. And for people who have diabetes and CVD, then their LDL cholesterol goal is 70 milligram per deciliter. In addition, lifestyle modifications focusing on reducing the saturated fat and on increasing the physical activity levels are important, and antipsychotic agents that contribute to the development of metabolic syndrome and increasing the risk of type 2 diabetes and heart disease is mostly encountered. Therefore, we should monitor their use very carefully. In addition, medications such as steroid, beta blockers, and diuretics can have or can cause hyperglycemia in some patients. Also, supplementation of vitamin C may cause a false positive urinary glucose level when it is given in large doses. Therefore, we should even assess the patient supplement intake to determine their response to treatment. Also, melatonin may have a role in managing glycemic control, as carriers of the risk of genotype can exhibit an increased expression of the gene in the islet cells, as these individuals may be more sensitive to the action of melatonin, leading to the impaired insulin secretion. Also, blocking the inhibitions of insulin secretion by melatonin may be a novel therapeutic avenue for type 2 diabetes. In addition, metformin can improve the insulin sensitivity in patients who have impaired glucose tolerance, but it doesn't reduce the inflammatory markers levels. Also, a medication that is a fat blocker can help to cut the heart risk in patients with type 2 diabetes. Also, the obese diabetic patient who is poorly controlled may benefit from a weight-reducing agent such as sibutramine or Orlistat. In terms of using herbs, they shouldn't be used without discussing with the physician, as these can have some side effects on the patient's condition. For vitamin D and calcium, in a combined supplementation, this can be beneficial to optimize the glucose metabolism in some patients. For nutrition counseling, the medical nutrition intervention in a patient who have diabetes should address the metabolic abnormalities of glucose, lipid, and blood pressure all at the same time. And to meet the specific need of the patient, we should adapt the medication therapy to enhance the outcomes and the quality of the patient's life. Also, DSME is an essential element in diabetes care, and the national standards have been based on the evidence for its benefits. This method helps the patient optimize the metabolic control, prevent and manage complications, and also maximize the quality of life in a cost-effective manner. In addition, healthcare providers should refer to the newly diagnosed patient to a dietitian, who should then regularly assess the patient over time for their modification in the medication and in their food intake patterns. We should also emphasize the importance of a regular mealtime, the use of medication on time, self-care, and optimal functioning with instruction on how to handle illness, stress, exercise, reading the food labels, and the use of sucrose or fructose, and also the sugars alcohol. In addition, vegan diet can increase the intake of carbohydrate, fiber, and also several micronutrients even more than the American Diabetes Association can recommend. So it would be acceptable to promote a vegan lifestyle for diabetes management for some of the cases. In addition, some restaurants can offer food that is low in cholesterol, fat, and sodium, and even high in fiber. And all restaurants can offer low-caloric sweeteners in a blue, yellow, or even pink packets, and also diet drink. Therefore, educating the patient on making healthy choices is very important. In addition, many can offer a reduced caloric salad dressing, for example, and a low-fat or fat-free milk and salt substitute, depending on the patient request. Therefore, we should advise the patient to choose salad and vegetables with baked or even boiled food to have a better nutritional value. Also, clinical trials using anti-hyperglycemic medication to improve glycemic control haven't demonstrated the anticipated cardiovascular benefit in patients who have type 2 diabetes. In addition to improve the glycemic control, we should assist with weight maintenance and reducing the risk of CVD at least at 150 minutes per week of a moderate intensity aerobic physical activity. This will lead to maximizing the heart rate and improving the patient's condition. Also, the activity should be distributed over at least 3 days per week with no more than 2 consecutive days of without any physical activity. And while the high intensity exercise is beneficial, even that in older adults, it should start gradually and then increase to the desired intensity level and duration. Therefore, we shouldn't instruct the patient to immediately start with 30 minutes of exercise per week, but we should start gradually with even a slightest start as 5 minutes per day. Then this should be increased to 10 minutes per day, depending on the patient improvement and complications levels. We should also avoid high-intensity exercise and resistance training in persons who have neuropathy, coronary heart disease, or even retinopathy. And in the absence of any contraindications, people with type 2 diabetes should perform resistance exercise 3 times per week, targeting all the major muscle groups and also progressing to 3 sets of about 8 to 10 repetitions. We should also instruct the patient to decrease the sedentary behaviors, especially prolonged TV or computer time. In addition, we should identify the potentials or real obstacles that prevent the patient from having any physical activity. Also, we should discuss the options for handling the negative emotions, temptation, and dining away from home, and the feeling of deprived and time pressure that can have some negative effect on their patient commitment to the medication. Also, regular consumption of breakfast and self-wakening and infrequent intake of fast food with strategies that all work well to manage the patient's condition. We should advise the patient to use a culturally appropriate method for teaching and guidance. For example, we should use the medicine wheel in Plains Indians that have shown more effective results than the usual techniques. This is because it is more accommodated to the patient's ethnicity and background level. Also, we should encourage group support, behavior modification, and nutritional counseling for overweight. Also, small changes can lead to greater self-esteem rather than setting big goals and the patient will feel unable to meet those goals. Therefore, this will have a negative impact on their health. And a sequential rather than stimultaneous dietary changes work well for most of the people and can improve the sense of self-efficacy. Also, a comprehensive lifestyle with self-management program using a Mediterranean low-saturated fat diet with stress management, training, and exercise group with group support and smoking cessation all can reduce the cardiovascular risk factor. So the dietitian should have a distinct role in the medical therapy for patients with diabetes, and both with education and counseling, which are more medically effective than either one alone. So a low literacy tool that can be useful in teaching the key changes for those who need it, with the goal to achieve a sense of control over self-management for diabetes management. And before any type of surgery, blood glucose should be maintained between 100 to 200 milligram per deciliter. And in the preoperative hyperglycemia, this can be managed with doses of rapid-acting insulin, even if the patient was only using oral glucose control method. We should also correct any abnormalities before the surgery when possible. Also, in a non-critically ill hospitalized patient, a pre-meal blood glucose should be kept as close as to 90 to up to 130 as possible, with postprandial blood glucose level of 100 maximum. We should, in some cases, use insulin if it was necessary. And in a critically ill hospitalized patient, blood glucose level should be kept as close to 110 and as possible with generally up to 180. So these patients will usually require intravenous insulin, which is temporary until they are out of the hospital, depending, of course, on the condition. We will be taking a break now for a Isha prayer, and then we will continue with discussing type 2 diabetes in children and in teenagers. السلام عليكم ورحمة الله. Welcome back everyone. بالنسبة للي بيطلبوا إن الدورة تكون متصلة، يعني المحتوى دسم وانتم مسجلين في دورة 20 ساعة، وأكيد ما حد يقدر يدي دورة متصلة ما لا يقل عن 5 ساعات بدون أي بريكات حتى للصلاة مثلا. فإنها تكون متصلة لا يمكن تطبيقها أبدا بسبب بريكات الصلاة. So we will continue with discussing type 2 diabetes in children and in teens. So type 2 diabetes can arise because of insulin resistance, as discussed earlier, when there is a failure to use insulin properly combined with relative insulin deficiency. So in children, obesity or puberty that often unmask type 2 diabetes in a genetically susceptible individual. So for example, the emergence of type 2 diabetes presents a new challenge for the pediatricians and other healthcare professionals with preventative effort and early diagnosis with collaborative care of the patient and their family, which is essential. So breastfeeding and reducing the television time with the sedentary lifestyle and healthy eating habits with family-based approaches and also screening are all considered important in managing this diabetic epidemic in children. So screening should be available for children whose BMI is greater than the 85th percentile at puberty or at the age of 10, plus any older children with any one of the two following factors. If the child had a family history of diabetes and if they had an increased risk by accordance to their ethnic group, such as Asians, as we have discussed earlier, and if they have signs of insulin resistance, such as polycystic ovary syndrome, hypertension, dyslipidemia, or acanthosis. Also, weight that is greater than 120% of the ideal weight or height is considered as a warning sign for screening against diabetes. In addition to obesity, family history of type 2 diabetes and the absence of GAD antibodies in children who have a newly onset of type 2 diabetes can be distinguished from those with type 1 diabetes by a combination of biochemical parameters of the C-peptide and the IGFBP1 and the CO2 with urine ketones levels. So 1/3 of children who have type 2 diabetes can also have at least one detectable beta cells autoantibody that is classified as a latent autoimmune diabetes in the youth. Also, fasting blood glucose level should be checked at least every 2 years in those who are considered at high risk. And type 2 diabetes in childhood can lead to end-stage renal disease with mortality in middle age and long duration that is more detrimental with severe health implications. Also, there is an ongoing effort for diabetes prevention in trials that are specifically designed to address adolescent population. In terms of the intervention, we should aim to maintain as near normal blood glucose level as possible by balancing the food intake with insulin, either an endogenous source or exogenous source, or even oral glucose lowering medication, and assessing their activity level. Also, we should try to maintain that the A1C level is 7% and no more. And the target range for the patient can vary by age and the underlying disease as according to the following. In children who are 6 years and younger, their A1C level should be between 7.5 to 8.5%, and those between 6 to 12 should have 8% of the A1C, and also those who are 13 to 90 should have A1C level that is not higher than 7.5. For the prepharyngeal capillary plasma glucose level, it should be kept between 90 and 130 milligrams. We should also protect the beta cell function by controlling hyperglycemia, and the A1C test should be done at least twice a year in patients who are meeting their treatment goals, and therefore quarterly in patients who are not meeting their glycemic control. We should also achieve optimal serum lipid levels to reduce the risk for macrovascular disease, and we should emphasize on medical nutrition therapy that has lifestyle strategies to reduce hyperglycemia, dyslipidemia, and also hypertension. Also, we should prevent and treat acute complications and short-term illnesses with also exercise-related problems and the long-term complications such as renal disease, autonomic neuropathy, and hypertension with CVD. We should also maintain blood pressure levels that reduce the risk for vascular disease, and elevated blood pressure levels that has major impact on renal function. Therefore, it should be controlled to avoid the presence of any complications. We should also improve the overall health through optimal nutrition and physical activity, and dietary guidelines from the American Dietary Association and the My Biodynamic Food Guidance System can illustrate the nutritional guidelines which can be used by young people who have diabetes. Also, we should encourage the patient to have regular meal times. This can help in controlling their blood glucose levels, and they should maintain lifestyle changes through behavioral modification, education, and also problem-solving strategies. In addition, working with the whole family is important in order to have a more comprehensive approach or strategies to be implemented over the long term. We should also promote family and individualized psychosocial counseling to handle depression and emotion that could develop for children who have strict diet. Also, we should address the individual needs according to the culture, the ethnicity, and lifestyle, while respecting the willingness to change. In addition, we should encourage therapeutic lifestyle changes considering the child need and family circumstances, and we should manage the problems that are related to compulsive or binge eating with patients who are often reporting deliberate omission of medication in order to lose weight. We should also educate the patient about calculating the carbohydrate and fat requirement individually according to their age, serum lipid, and glucose level. We should also assess their dietary history, their physical exercise, and also their activity patterns. Also, studies support that the importance of carbohydrate from whole grain, fruit, vegetables, and low-fat dairy products or milk in specific in having a better glycemic control. And the moderate weight loss of about 10% of the starting weight can reduce hyperglycemia, dyslipidemia, and also hypertension. And the moderate restriction of the calories of about 500 kilocalories per day, less than the average daily intake, and a nutritionally adequate meal plan are recommended to enhance weight loss and the general health. And for teenagers, boys who are over 15, it can be useful to calculate their caloric needs as 18 kilocalories per IB for the usual activity and 16 kilocalories if they were sedentary. And for teenager females over the age of 15, they have the need that is estimated the same as those for adults, and there is no adjustment for that. And an extremely low caloric diet are not recommended for children or teens. And in morbidly obese children, a gastric bypass surgery should be the last options, as malnutrition is a permanent side effect for that. In addition, spacing of the meals, such as spreading the carbohydrates through the day and also eating breakfast, have beneficial effects on the fasting blood levels and also on the postprandial insulin sensitivity. And meal skipping should be discouraged for all patients with an individualized meal plan according to the patient preference. So to calculate the carbohydrate intake, as mentioned previously, it should be between 45 to 65% of the total energy intake, with fiber not less than 20 grams per day. So the daily consistency is important to ensure normal glycemia, and protein should be calculated at about 15 to 20% of the daily energy intake with the normal renal function. But in the presence of renal disease, then this should be at 0.8 to 1 gram per kg. Also for fat, it should be between 25 to 35% of the energy intake, and with about 7 to 10% of the caloric as saturated fat, and 10% as polyunsaturated fat, with about 10 to 15% as monounsaturated fat. Also for cholesterol, it should be limited to about 200 to 300 milligrams per day. So the recommendations for fiber include rice, beans, vegetables, and products that have skins to increase their fiber content. And we should increase the fiber content of up to 40 grams per day in larger amount for older children and teenagers. And as a part of a healthy lifestyle and to manage also hypertension, we should teach the principles of DASH diet that is specifically made for persons who have hypertension. And according to this diet, the sodium content is restricted to 2,400 milligrams. Also for vitamins and minerals, we should ensure that the patient has adequate dietary intake, and higher level of magnesium, chromium, and potassium are recommended when the serum levels are low. Also, there are no need for supplementation of any singular nutrient, as a pediatric multivitamin mineral supplement can be sufficient. But we should include a phytochemical and antioxidant in the diet. This is to enhance their immunity in general. We should also discuss the use of artificial sweeteners and food diaries and menu options at school with fast food choices that are lower in total fat which have higher benefit and goals, and for the physical activity recommendation and the recommendation for adequate fluid intake. So a comprehensive education regarding their food intake and what to choose outside the home of different dietary menu is recommended, as children and teenagers are more likely to be more picky eaters. For the common medications that are being used in type 2 diabetes for children, an oral agent may be used when the blood glucose and other treatment goals are not met through diet and exercise alone. And the glucophage should be the first oral agent used, but not in children who have a liver disease and kidney disease, as low oxygen problem or severe infection can develop. Other oral agents such as sulfonylurea or megalofenatide can be added if the control doesn't improve after 3 to 6 months. And for thiazolidine, that probably shouldn't be used in children as it can have adverse effects. Also, insulin therapy should be started in children who have severely elevated blood sugar level or in children who have intense thirst and frequent urination. So the startment of insulin therapy depends on the patient's condition. So there are a wide variety of insulin regimen that can be used, anywhere from a bedtime alone units to even multiple daily injections. And once the blood sugar are under control, then glucophage can be added while we decrease the insulin dosing. In terms of the pharmacological options for weight loss, including metformin, orlistat, and the cetramine have been studied, and they should be used only under close medical supervision as they could have some possible side effects. In regard to herbs and potential supplements, these shouldn't be used in children and in teenagers, as there is no sufficient evidence to draw a definitive conclusion about the efficacy of individual herbs and supplements for diabetes, especially in children. Nonetheless, the inclusion of some spices and seasoning in the diet would be acceptable as long as it is not in a high amount that would produce a negative effect. For nutrition education and counseling, the healthcare providers are encouraged to refer the newly diagnosed patient to the dietitian, and they should regularly reassess the children for their overall growth and health status, and also their commitment to the dietary implementation. In addition, stress on the importance of the parental supervision and support is very important. Moreover, children often benefit from attending a diabetes campus for the youth and support group for the family counseling, as all can improve their health. As DSME is helpful for maintaining the blood glucose level, medication use, and physical activity goals with meal planning, we should emphasize the importance of regular meal times, proper use of medication, and a balanced activity. So home blood glucose monitoring, keeping record, and also food and exercise record are all important to assess the patient compliance and if there was any adjustment that is required. We should also emphasize the importance of self-care and optimal functioning for illnesses, stress, dining out, and exercise. We should also identify any potential or real obstacles with discussing the options for healing or handling the negative emotions, temptation, and also dining away from home, as these children can have a feeling of deprivation with time pressure and computing priorities with the socio-economic effect. We should also explain to the patient food and nutrition labeling, as well as how to manage sucrose for sources in the food, fructose, and also sugar alcohols in the diet. We should also reduce the sugar-sweetened beverage intake as much as possible. In addition, we should encourage group support, behavioral modification, and also nutrition counseling for individuals who are overweight. In addition, having the whole family attend a support group is very important to enhance the child commitments to the diet. And small changes that lead to greater self-esteem than continued failure is more likely by setting small goals to achieve the bigger or main goal, which is having a normal glycemia. And sequential rather than simultaneous dietary changes work best and can improve the self-efficacy. We should also reduce stress where it is possible. And for BMI with stress, these are independent determinants of the TNF-alpha, which is the inflammatory cytokines, which can also have adipokines among the Latino children that all can have a negative impact in their health as a stress indicator. So the suggested guidelines for physical activity are 3 to 4 times a week, with exercise for about 30 to 60 minutes. Also, aerobic exercise is protective against the age-related increase in the visceral adiposity, so it can improve their current blood glucose control and also their long-term health outcome. In terms of foodborne illnesses for the patient education, if the patient was using home tube feeding, then we should teach the patient on appropriate sanitation and food handling procedures. So, as we have discussed, that diabetes is a chronic metabolic disease that is characterized mostly by hyperglycemia as a cardinal biochemical features. So the major forms of diabetes are differentiated by the insulin use as insulin deficiency versus insulin deficiency. That is type 1 and 2. So we have discussed type 2 in children, but in type 1, the result from a deficiency of insulin secretion because of a pancreatic beta cell damage in total. While type 2 is a consequence of insulin resistance occurring at the level of skeletal muscle, liver, and adipose tissue with various degrees of beta cell impairment. So it can have a partial impairment. For morbidity and mortality, it stems from a constant potential for an acute metabolic derangement and also from a long-term complication that usually occurs in adulthood, which affect the small and the large blood vessels, resulting in retinopathy, nephropathy, neuropathy, and ischemic heart disease with arterial obstruction, and even gangrene of the extremity for a simple scratch, for example, of the foot. So type 1 was formerly called the insulin-dependent diabetes mellitus or the juvenile diabetes. It is the most common endocrine metabolic disorders of childhood and of adolescence. So type 1 diabetes is characterized by destruction of the pancreatic beta cells, leading to an absolute insulin deficiency. Therefore, in this case, they will require insulin injections. So this is usually due to autoimmune destruction of the beta cells, as in type 1A, which comprise about 85% of type 1 diabetes. Or this could also be idiopathic due to unknown cause. This is type 1B and compromises about 15% of type 1 diabetes cases. So about 80% of the newly diagnosed diabetes in patients who are younger than 19% are those having type 1 diabetes. And the onset can occur predominantly in childhood with a median age of 7 to 15 years, but it can also be present at any age, not specific. So the incidence of type 1 has steadily increased worldwide in children. For the epidemiology, the evidence can vary depending upon several factors, including, for example, the geography, as the highest reported cases of type 1 are in Finland and in Sardinia. This corresponds to a percentage of about 37 to 65 individuals per every 100,000 persons. Also, the age and the gender play a role in the presence of diabetes, as the bimodal distribution of one peak at 4 to 6 years and second peak in early puberty about 10 to 14 years. While in the male-female ratio, males are more likely to have type 1 diabetes than females. Also, as mentioned, family history and ethnicity can have a various effect on the development of type 1 diabetes. For the genetic susceptibility, if the patient had no family history, then they would have a 0.4% developing diabetes, which is considered a very low percent. And an offspring of an affected mother would have about 1 to 4% risk of developing type 1 diabetes. And an offspring of an affected father would have a risk of up to 8% of developing diabetes mellitus. While if an offspring had both parents affected, they would have a risk as high as 30% of having diabetes. When in a no-twin sibling, the affected patient will have about 6% risk of developing diabetes by the age 20, and this can increase to 10% by the age 60. And in the dizygote twin, this will increase to 8%, while the monozygote twin can have a very high risk of 30% within the first 10 years with a history of a twin, while it can increase up to 65% by the time they are 60 years of age. For the pathogenesis, both the genetic susceptibility and the environmental factors can contribute to the pathogenesis. While also the autoantibodies to the beta cells antigens, such as the isolate cell cytoplasm and the insulin autoantibodies with the antibodies to the glutamic acid decarboxylase, can all be detected months to even years before the clinical onset of type 1 diabetes. So in type 1 diabetes, it is associated with other autoimmune diseases, such as thyroiditis, celiac disease, and also Addison disease. So all of these can be accompanied by a person who have, or a child who have type 1 diabetes. There are also some environmental risk factors that can increase the person's risk of developing type 1 diabetes. First one is a viral infection. Even though there is no single virus or pathogenic mechanism, mostly in genetically susceptible hosts, this is an invoked mechanism that involves a direct infection of the beta cells by viruses, lysis, and also the release of self-antigen. So a direct viral infection of antigen-presenting cell causing the decrease of expression of the cytokines, and also a molecular mimicry with the notion that a viral antigen can exhibit a homology to self-apoptotic effect, which can destruct the beta cells. There is also the congenital rubella syndrome. This is prenatal infection with the rubella that is associated with beta cell autoimmunity in up to 70% of the persons who have type 1 diabetes. This can increase with the up to 40% for the infected children with enteroviruses and mumps viruses can all lead to the development of beta cells autoimmunity. So these three viruses can all affect the beta cells and lead to the destruction of them, which can cause type 1 diabetes. So the hygiene hypothesis is another hypothesis on how type 1 diabetes develops. This is a possible protective role of infection and state that the lack of exposure to childhood infections can increase the individual chances of developing any autoimmune disease, including type 1 diabetes. Also, diets such as breastfeeding can lower the risk of developing type 1 diabetes, as early introduction of cow milk protein and the exposure to gluten development of the autoimmunity can have some negative effect on the child health. In addition, the deficiency of some nutrients such as omega-3 fatty acid, vitamin D, vitamin C, zinc, and vitamin E can all possibly have a negative effect on the development of type 1 diabetes or the child immunity in general. Also, the psychological stress, such as whether aggravated pre-existing of the autoimmunity can trigger the autoimmunity remains, which is unknown, but can have some possible effect or trigger. There is also an idiopathic type 1 diabetes in which there is no immune mediation for the development of the disease. This occurs in patients who have an African or Asian origin and is a distinctive form that is known to cause beta cells destruction, such as drugs or chemical, viruses, mitochondrial gene defect, or a pancreatectomy. All of these are considered as a possible hypothesis for the idiopathic type 1 diabetes. So they may have ketoacidosis in these cases, but they can also have an extensive periods of remission with variable insulin deficiency that is similar to patients who have type 2 diabetes. The natural history for type 1 diabetes include that the preclinical beta cells autoimmunity can have a progressive defect of insulin secretion. So therefore, this is followed by the onset of the clinical diabetes and the transition remission of the honeymoon period in which the patient condition has stabilized and the insulin is normal with the normoglycemia for a period that is known as the honeymoon phase. Then we have established diabetes, during which there may occur acute or even chronic complication with decreased life expectancy depending on the severity of the condition. So this is a diagram to symbolize the occurrence of type 1 diabetes. First of all, as we said, the genetic susceptibility plays a major role, and then the person could be exposed to an unknown environmental trigger which will affect the immunity, the autoimmunity, and then we will have a progressive beta cell loss, which can lead to clinical diabetes and then clinical remission or either complications. But if this didn't affect the beta cells, then there will have no diabetes. But if a genetic person who have a genetic susceptibility didn't become exposed to the trigger factor, then they wouldn't develop the autoimmunity destruction against the beta cells, and then they wouldn't develop diabetes. So it is a multifactorial interaction between a person who is genetically susceptible and an environmental factor. Another type of diabetes is the latent autoimmune diabetes in adults. In this condition, they will have a circulating autoantibody directed against the pancreatic beta cells antigens, the ICAs, or the GAD65. In the heterogeneous group of patients who have variable titers of the autoantibody of the antibodies and their BMI who have frequency of progression to insulin dependence. While in the genotype analysis, the LADA gene can share the genetic features of both type 1 and type 2 diabetes, so it can be somewhat of a mixed type. For the clinical presentation, in the first stage, there is multiple isolate or beta cell isolate autoantibodies in the with normal blood glucose and pre-symptomatic period, which is honeymoon phase. While in stage 2, there is multiple isolate autoantibodies and a raised blood glucose level, and also they are still pre-symptomatic. While in the third stage, there is isolate autoimmunity that has developed with hyperglycemia, and then the patient at this time will have developed the symptoms. And in stage 4, there is a long-standing definitive diagnosis of type 1 diabetes. And for clinical purposes, the usual initial presentation remain as the following. In the classic new onset form, there is a chronic polydipsia, polyuria with the glucose level more than 10 millimole, and there is also weight loss as with type 1 diabetes that is accompanied by hyperglycemia and ketonemia or even ketonuria. This is the commonest presentation of childhood who have type 1 diabetes, and there are other presentations including preanal candidiasis, and the patient usually appear very sick or doesn't appear ill at all. And in the second one, which is the diabetic ketoacidosis phase, this is the most common form of presentation for patients who have type 1 diabetes. So the similar is the diagnosis or the history, but usually have more severe than those of patients who doesn't have acidosis. And the fruity smelling breath and also neurological finding, including drowsiness and lethargy, is also a common feature in those patients. So the classic pediatric history of dehydration, decreased urination, are all masked by the polyuria that is associated with glucosuria. And in about 30%, it is an initial presentation for type 1 diabetes. And in children less than 6 years of age, or those who are from an adverse socioeconomic background, those are more likely to have DKA as the first initial presentation symptom. And those who are younger than 3 years of age, more about 50% of them has DKA also as their initial presentation of type 1 diabetes. There is also the silent asymptomatic incidental discovery type. So this is diagnosed with type 1 before the onset of any clinical signs. And this is the least common presentation that typically occurs in those with a close family member who have type 1 diabetes and are being closely monitored accordingly just for the presence of an affected family member. So the history is often made by either a family member, a clinician with a high index of suspicion, or the diagnosis is made accordingly. So these children can be classified as having stage 1 or 2 diabetes using the International Society for Pediatric and Adolescent Diabetes, the guidelines for the diagnosis. The second type, which is type 2 diabetes, this was formerly known as adult onset diabetes or the non-insulin dependent diabetes mellitus. So children with this type of diabetes are usually obese, but they are not insulin dependent and infrequently develop ketosis. This is characterized by insulin resistance and often a progressive defect in the insulin secretion. So the endogenous presentation is unlike type 1 diabetes, as there is excessive weight gain and fatigue, where in type 1 diabetes there is weight loss. Also, the incidental finding of glycosuria during routine examination is the most likely to happen. Also, the incidence in children has increased by more than about 10-fold, depending on the geographical location, and mostly as a result of an epidemic of childhood obesity, which is a substitution for the development of diabetes. In addition, the incidence of type 2 diabetes has completely inverse a relationship with the birth weight and in some population in specific. So the pediatric type 2 diabetes can account for about 80% of the new cases of diabetes, especially in the obese African American and Mexican American adolescents. Therefore, the genetic susceptibility play a major role in the development of type 2 diabetes in children. So this is known as acanthosis nigricans, which is a dark pigmentation of the skin creases in the nape of the neck especially, and also considered as a sign of insulin resistance. This presents in the majority of patients who have type 2 diabetes and is accompanied by a relative hyperinsulinemia at the time of the diagnosis. So a slight changes in the back of the neck color or the armpit can be considered as an early identification source or sign for the presence of insulin resistance. And even though the serum insulin elevation is usually disproportionately lower than that of the age and the weight and also the gender match non-diabetic children and adolescents, This suggests a state of insulin insufficiency in most of the cases. For the classification of diabetes and also the genetic diabetic syndrome, the polymorphism of a multiple gene are reported to influence the risk of type 1 diabetes, including the genes in both the major histocomplexity complex and also in the genome. But only the human leukocyte antigen alleles have a large effect, followed by insulin gene polymorphism and the BTC2 genes. So genes, as we said, play a role in the development of diabetes. In the monogenic diabetes, this was formerly known as the maturity onset diabetes of the young. So this is a group of monogenic disorders that are characterized by AD inherited of an insulin-dependent form of diabetes. This classically presents in adolescents or young adults before they are 25. So in this condition, there is a strong family history of diabetes, and this accounts for about 2 to 5% of the cases of diabetes in general. So this condition should be suspected in a patient who presented with an insulin-dependent diabetes at a young age, younger than 25 years. Also, in a patient with an autosomal AD transmission across 3 generations, with the lack of isolate autoantibodies and the lack of acanthosis nigricans as a presenting feature for diabetes. Also, in the monogenic defect, there are a hepatocyte nuclear transcription factor of the 4 alpha genes, and there is glucokinases, the HNFA1, and then insulin promoter factors with HNF1 beta and NeuroD1 with mitochondrial DNA effect. So all of these are depicted in the monogenic type 1 diabetes. So the diagnosis of monogenic DM is made by performing diagnostic genetic testing through a direct sequencing of the gene. So it may require insulin treatment and can be treated with sulfonylurea with a varying degree of success depending on the severity of the underlying cause. So a defect in the gene, this is the type 2 diabetes where a genetic defect can occur, and a defect in the gene that is regulating the glucose transport into the pancreatic beta cells, which is the glutathione 2 transporter, can be responsible for the other form of type 2 diabetes. So the genetic basis for type 2 diabetes also include a defect in the glycogen synthesis, also in the insulin receptors, and in the RAD, which is the RAS associated with diabetes, and in addition to a defect in the apolipoprotein C3. So in most cases of diabetes, there is a genetic implication or a genetic modification that affects the condition. For other specific types of secondary diabetes, as DM secondary to the exocrine pancreatic disease, such as that can occur in the case of cystic fibrosis. While in other endocrine disease, such as Cushing's syndrome, this can be also accompanied by secondary diabetes. Also, some drugs or poisons can lead to the development of diabetes, and in the post-transplantation phase, DM can or have been linked to the cyclosporin and tacrolimus treatment that is usually initiated after any transplantation is made. So how can we distinguish type 1 from type 2 diabetes? In type 1 diabetes, this is, as we said, is insulin dependent, and patient can only be treated by using insulin injections, as there is a complete destruction of beta cells. While in type 2, this is insulin resistance and can be insulin dependent in some of the cases. As we have discussed, some of the patients will only use oral glycemic control pills, while others can need insulin injections. So in type 1, there is DKA, while in type 2, there is acanthosis nigricans as a presenting sign. And in type 1, the patients are usually underweight and usually lose weight at the diagnosis. But overweight is also present in about 20 to 30%, in which those can have insulin resistance and other factors of type 2 diabetes. And in type 2 diabetes, there is also DKA that can occur also in the case of severe infection, for example, and patients are most likely overweight, not like in type 1. Also, type 1, as 10% of the patient can have an affected cousin or family member or close relative with type 1, as it can increase the risk of developing the disease. While type 2 diabetes can have about up to 90% chance of having an affected close relative with diabetes, which can increase their genetic susceptibility. Also in type 1, the patient will usually present with hypertension, dyslipidemia, and polycystic ovarian syndrome in female patients. For the lab tests that are helpful in differentiation between type 1 and type 2 diabetes, the first test is the antibodies. In type 1 diabetes, the presence of a circulating isolate specific pancreatic autoantibodies against the GAD65 of the fragment of the tyrosine phosphate and insulin or even zinc transporter is usually present. While there is an absence of the autoantibodies, that doesn't or have the possibility to develop type 1 diabetes. There is also up to 30% chance with the classical appearance and presentation of type 2 diabetes that have positive autoantibodies and can also have a slowly progressive type of autoimmune diabetes that is developing. Another test is the insulin and the C-peptide levels, as there is a high fasting insulin and C-peptide level, which can suggest the presence of type 2 diabetes. While if their levels were low, then this will indicate the presence of type 1 diabetes. In addition, they may be suppressed by severe hyperglycemia and also illnesses. Therefore, it is best to assess them after the patient has recovered from the acute illness, which can affect their level. So during stress, the levels can be affected. In addition, the ethnicity such as Hispanic has a higher level of insulin and C-peptide levels in general. And some patients can have a mixed features or which are difficult to classify, as for example, in the US, the pediatric diabetes was classified among the presence or the absence of the beta cells autoimmunity and also the presence or absence of the insulin sensitivity in general. And more than 70% of the patients fell into the traditional categories of the autoimmune and insulin sensitive type 1 diabetes, which is about 55% of the cases, or the non-autoimmune and insulin resistance type 2, which represent about 16% of the cases. Also, 20% of the patients had both autoimmunity and insulin resistance, which is a pattern typical for an obese patient who have type 1 diabetes. And 10% of the patients were insulin sensitive in the absence of an islet cell autoimmunity, and most of which were clinically categorized as type 1 diabetes type 1B, while the remainder as a type 2 diabetes, which is suggestive for that patient can need additional evaluation for the possibility of monogenic diabetes that is formerly known as maturity onset diabetes of the young. The differential diagnosis, or what is known as other causes of the occurrence of hyperglycemia other than diabetes. First of all, if we had a critically ill patient who is going under septic shock or other clinical illnesses, then their glycemic control abnormalities will develop. This doesn't mean that the patient have diabetes, but it just means that under stress factors or certain condition, the patient can become clinically ill. Also, some medications such as IV glucose infusion, acute sympathetic agent, and a high dose of glucocorticoid all can affect the blood glucose level, leading to hyperglycemia. In addition, the neonatal hyperglycemia, this condition can be caused by excessive glucose infusion, the prematurity of the infant, stress factors, sepsis, some medication, and also the transition or the permanent neonatal DF. So how is diabetes diagnosed? According to the American Diabetes Association, the following criteria must be present to diagnose a patient as a diabetic patient. The first one is that the A1C level should be more than 6.5, with the test that should be performed in a laboratory using method that is NGSP certified and also a standardized procedure to the DCCT assay. Or the patient could be having a fasting blood glucose level of more than 126 milligram per deciliter, and fasting is defined as no caloric intake for at least 8 hours. The third criteria for diagnosis is 2 hours plasma glucose level more than 200 during an oral glucose tolerance test. So the test should be performed as described by the WHO using a glucose load containing the equivalent of about 75 grams of anhydrous glucose dissolved in water, or in a patient who have classic symptoms of hyperglycemia or hyperglycemic crisis with a random plasma glucose that is over 200. So any of the following criteria can be used as a diagnostic method for diabetes. In terms of the oral glucose tolerance test, This is administered by giving the patient a glucose load of 1.75 gram for each kg, with a maximum dose of 75 gram in total. So the plasma glucose level of more than 200 milligram is measured after 2 hours and considered as an identification for diabetes. So most of the children are symptomatic and would have a plasma glucose concentration that is much more above than 11 millimole. Therefore, the oral glucose tolerance test is seldom necessary for the diagnosis of type 1 of diabetes in general. So this can be used as a single treat or diagnostic method for diabetes in general. For the A1C level, the glycated hemoglobin, it measures the percentage of the hemoglobin, the glycated hemoglobin that is bound to glucose via the non-enzymatic glycation, which indicate the average blood sugar level for about a period of 10 to 12 weeks before the times of measurement. So A1C measurement can tell us the blood glucose level over the past 3 months. So a level that is more than 6.5% is an accepted criteria for a certain diagnosis for diabetes in general in adults. But the diagnostic utility of A1C for children is less well established, as a level that is less than 6.5 doesn't exclude DM. So in children, it is better to do the oral glucose tolerance test, while in adults, we can do the A1C measurement. So in one study from Germany, all children with symptomatic new onset type 1 diabetes had their A1C level at more than 6.35. So in some situations, this can be diminished as a regular or a normal value, but all of them already have diabetes. So it is better to do the oral glucose tolerance test. Another test, which is the impaired glucose tolerance, this refers to the metabolic stage that is intermediate between the normal glucose homeostasis and diabetes. So the fasting glucose level, the normal level, is between 100 to 125 milligrams. And many patients or individuals with impaired glucose tolerance are euglycemic, as they can have a normal or a nearly normal glycated hemoglobin level at some time. So IGT often manifests only when challenged in the standardized oral glucose tolerance test. So this is combined sometime with the oral glucose tolerance test. Another indicator is the autoantibodies measurement indications. So patients with poor response to initial therapy who have sulfonylurea or metformin medication should be should be used for the measurement. Also, personal or family history of autoimmune disease can be as an indication for this condition. And overweight or even obese children or even adolescents who present with an aberrant type 2 diabetes who actually can have an early presentation of type 1 diabetes are considered to have this condition. So this is the end of our lecture today. بس الآن حيكون عندنا فقرة مناقشة. كان في كم استفسار أو أسئلة أول، لو ترجعوا ترسلوها الآن فضلاً عشان نناقشها، وأي أحد لو عندكم استفسارات فضلاً أرسلوها على الشات عشان نجاوب عليها. الله يعافيكم بالتوفيق. نعم يوجد شهادة وحترسل إن شاء الله. الله يعافيكم بالتوفيق جميعاً. إن شاء الله سيتم إرسال المادة العلمية لكم بعد انتهاء الدورة. تأثير السكر على الأعصاب الطرفية. يأثر طبعا على النيورو سيستم إن جنرال، وممكن يقلل الإحساس عند الأشخاص المصابين بالسكر. ما يوجد علاج حاليا، لكن يوجد intervention من البداية with proper management and treatment from the beginning and normal glucose control. This can be as a preventative method for preventing the neurological damage. للي بتسأل هل ممكن يتعالج السكر؟ for type 1 diabetes لازم طول حياتهم خلاص يستخدموا الانسولين injections، حيتحسنوا، حيصير normal glycemia يعني control if they are following the correct guidelines. لكن type 2 diabetes لو البيشنت كان عنده proper dietary control with accurate physical activity levels، ممكن بعد فترة يصير بس diet therapy وبدون أي medication لو كان هو فقط على الأورال glycemic agent not insulin. ففي المراحل الأولى type 2 ممكن إنه يصير له adjustment. الميتافورمين يأثر in specific على فيتامين B12، ممكن يعمل له reduction. Therefore, we should recommend a multivitamin and mineral supplement for the patient. The first sign or symptoms of prediabetes is the presence, as we said, of glucose misinterpretation. In specific, there are some measurement for glucose, as we mentioned previously, for the fasting and the intermediate glucose tolerance test. All can be signs of prediabetes with the presence of overweight, especially obesity, and also family history of diabetes. بالنسبة للي بتسأل هل يعطي قياس السكر تراكمي نتيجة صحيحة لمريض الأنيميا؟ في بعض الحالات وجدوا إنه ما بيكون دقيق، وممكن بالعكس يدي high result هم بيكون عندهم ال blood glucose level better than that. So الحل إنه يعملوا oral glucose tolerance test. مرض السكري ليس سبب رئيسي للفشل الكلوي. يعني ممكن الفشل الكلوي يحصل لحاله بدون وجود سكر، ولكن وجود مرض السكر مع poor glycemic control هو يعتبر من أكثر المسببات للرينال فيلير.